भारत एक युवा देश है। विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बात के लिए गर्व कर सकता है। दुनिया में हम आंख मिला करके बात कर सकते हैं। और ये मेरा साथ मैं हमेशा कहता आया हूँ, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया ग्रोथ।
Welcome everyone. I am Ravi Gupta. Welcome, and let me welcome our Honorable Shri A.L. Heck. He is the Cabinet Minister of Meghalaya, Department of Health and Family Welfare, Department of Home and Arts and Culture, Government of Meghalaya. And I welcome all the audience who are watching us live on Facebook to the Elets Virtual Healthcare Innovation Summit. This summit is in this context of this pandemic situation, which is happening globally. You can see on the agenda here live on the screen, and you can also check our event website for the detailed agenda. And today, in the inauguration of this summit, we have the Honorable Minister, Shri A.L. Heck, and we have the whole day lined up with health experts from all over the country, both from the private sector hospitals, government sector hospitals, and also the industry experts who are going to talk about how the health sector is going to be affected by this pandemic situation, and what are the challenges ahead in dealing with the situation. So as we start, I am requesting our inauguration, the it's happening of this summit, and we have our chief guest, Shri A.L. Hegji. He is the Cabinet Minister of Meghalaya, Department of Health and Family Welfare. We welcome you, sir. Thanks for joining us from Meghalaya, and we would request you to give us an idea about that. What is the COVID situation in Meghalaya, and how is your government dealing with the situation, sir?
Thank you very much, and good morning to you, Dr. Gupta ji. and all your friends from the Elets and all the participants who are participating in these discussions. About the coronavirus pandemic really has presented us with a very, very unprecedented crisis in all the sectors, including in the healthcare. So the healthcare system in the COVID-19 period, however, I would like to share with you, I feel it would emerge as a stronger and more vibrant form. This is because we have utilized the lockdown period in health system and strengthening and also training all personnel in all levels. When there is a severe problem, there also lies an opportunity during the COVID time. So I would like to tell you and update you the latest position of the COVID-19 in the state of Meghalaya till yesterday. So we have already tested almost 12,153. Okay, those we have already tested, those we have found negative, the report has come, there were 11,839. And those are tested positive, which is since yesterday it was 44 people, but 18 recovered, and now only 25 left for active person in the state of Meghalaya. Active cases in the state of Meghalaya, yes.
Excellent situation.
So Meghalaya being a hill state, we have a lot of challenges and in accessibility. The thing is, we have to see in infrastructural weaknesses, manpower shortages, and due to the COVID pandemic, we have realized that we need to strengthen the community, the district levels, facilities, and also prepare for any surge in case there is any requirement for specialized care facilities like beds, like oxygens, ventilator supports, ICU care in all the district levels. And also it has really taught us about, we realized that most of the district were lacking such facilities, as we have tried to provide them with all necessary basic life support care equipments. And also we have tried to provide them with all the necessary basic life support. As I told you, we have also provided them with all the oxygens, the cylinders, and all the peripheral health facilities. And also at the district level, we have provided the ventilators and also BiPAP, BiPAP machines, which we did not have previous to a COVID-19 pandemic. These are some of the steps that will help us in the future days. One of the important lessons, what the future that we have to minimize to human interactions, which is going to be very, very difficult propositions for the healthcare sector. We have started teleconsultation services. We have already started telemedicines, will be very important activity for us in the future. Another important, we have readjustment would be regarding the services where the community contact is unavoidable. So this is what we are required now. Then also, how to take the way forward. How to take the way forward would be a strictly ensure hand hygiene, cough etiquette, wearing masks regularly when you go to the public places, maintaining physical distancing, and also take all kinds of precautionary measures by the public when we are going out in the open areas. That is very, very particularly. And also when they visit any health facility, they have to be very, very cautious and take measures. Now in Meghalaya, the very, very important platform which we have is Mega Health Insurance Scheme. You must be aware that the government of Meghalaya is giving 5 lakh rupees to all the residents in Meghalaya through the Mega Health Insurance Scheme for all the treatment. It is been empaneled in all the public hospital and also the private hospital. This empanelment is not only in our state of Meghalaya, it is even empanelment to the state outside Meghalaya also. If you talk of Assam, you talk about Delhi, you talk about Bombay, there's so many hospitals. Both are in the government hospital and also the private hospital are empanelment with our MHIS platform. So this has given a very, very huge facilities and helping so many families and in receiving a quality healthcare at the government and also in the private health facilities under the MHIS. This is MHIS is known as Mega Health Insurance Scheme. We are giving 5 lakh rupees. This one also now we have included also with the what do you call this when they go for any kind of testing. Suppose they go for MRI, they go for blood test, they go for X-ray, they go for ECG, go for anything. You have to go with a doctor's prescribed slip, go to any hospital where the facilities are available, do the test, and just walk out without any pocket expenses. Out of pocket expenses, we are providing through the MHIS. And also in future, we are exploring the ways as much as possible how to further strengthen this system in our state under the MHIS. We can also consider laying down some basic services, charges for those who can afford it. Last but not the least, I just like to share with you, as the COVID has taught us, the community involvement is going to be essential and very, very effective in healthcare delivery in the future days to come. So that much only I'd like to share with all of you, and thank you. Namaskar.
Namaskar, and thank you so much, Honorable Minister, for updating the good work which the government of Meghalaya is doing, and great to hear that you are actually providing a good insurance scheme, and the patients can actually get their treatment not only from your state but anywhere in the country, and it is a great.
Anywhere in the country which is empaneled with our government.
Okay, fantastic. And one thing to ask you is that the lot of migrant population is returning back to your state in these situations. So how are you handling the situation in controlling any spread of disease?
See, till today, we don't have any community transmissions.
Okay.
We are containing very well. Okay. So far, from people from outside Meghalaya, those has come back to Meghalaya, to Shillong, to our states, there are 14,754 till yesterday. 14,754.
Okay.
So what we are doing from the government of Meghalaya, we have set up 2 counter or office in Guwahati, one in Guwahati airport, one in the railway station.
Okay.
Anybody who is coming, those are people are from Meghalaya, those are coming from different part of the country. If they are coming by flight or by train, if they are coming by flight, they have to go to the counter which has already been set up there in the airport. They do the registration there, give all the details. Then those are coming by train. There also we have set up the counter there. They can come to the counter which is already set up for the people of Meghalaya. They can do the registration there. Then the government of Meghalaya is providing the vehicle to all of them, those returnees coming from outside the state. If they are coming anytime, any moment, if they are there in our counters which are set up in both places, we are taking them all back to Shillong. But before coming to Shillong, coming to our state, we have the entry point. You have to screen everybody who are coming to Meghalaya from these screening points which are set up just after crossing your Guwahati. Okay. After doing the screening, we took them directly to the institutional quarantine center. At the same day, we told them, today you take rest, relax, have food, take your bath. Then tomorrow, what we did, we collect their sample, the swab from them. Then after we are collecting the sample, we send it to the lab for testing, to Negrims, and also we have in Shillong and Tura also. So we do the testing. After the testing, if we found negative, then we give them optional to either they go for home quarantine, they go to the paid quarantine, or they go to the government institutional quarantine. Whatever optional we are giving to them, only to those people, those are tested negative. But those who are found positive, we take them straight to the COVID hospital.
Fantastic. So, uh, excellent inputs, and uh, great to hear that how the state is handling the situation. And we would be launching the special issue of the eHealth magazine. eHealth magazine is a magazine which was launched in 2005, and it is India's first and the only magazine on healthcare, IT, healthcare innovations being published every month. So I request my colleagues to put on the screen this eHealth magazine cover of this issue of June, and we are requesting the Honorable Minister to do a virtual launch of this issue of the magazine, and it will be available online right now and will be printed and sent to everyone. So we are launching this latest issue in your presence virtually with you. So thank you for addressing
Thank you very much. Thank you.
this launch. So with this, we will be ending this inaugural session of the Honorable Minister. Thanks for joining, sir. Namaskar to you.
Thank you.
Thank you so
Good
much.
day. Namaskar.
Thank you. Thank you. So after this inaugural session is over, we are here. Hello, Amrita. Thanks for joining us.
Hi, good morning.
Hi. Good morning. We have our panelists here. Dr. Hari Prasad is here. Dr. Alok Ray is here. Welcome. And we are going to wait for our other presenters. So let me introduce the session. This session is a panel discussion on redefining healthcare sector in the post-pandemic world. And our panelists are Dr. Alok Roy. He is the chairman and managing director of Medica Super Specialty Hospital, Kolkata. Dr. Alok, thanks for joining us. And namaskar. Thank you. And we have Dr. Hari Prasad. He is the president of Hospital Division, Apollo Hospitals. Thanks for joining us, Dr. Hari.
Hi,
Namaskar.
thank you.
Thank you. And we have Amrita Dupelia. She is the Associate Franchise Director, Advanced Sterilization Products, Johnson & Johnson. So I'm requesting Amrita to start her presentation, which is the presentation on importance of sterilization. And I will request our other speakers to keep their mic on mute, please, so that we will reduce the background noise. Dr. Hari Prasad, yeah. So Amrita, requesting you to start your presentation, please. Welcome.
Thank you very much, Dr. Ravi, and thank you to the organizers for giving us this opportunity to come and really share what we are seeing in this new world that we're living in today, and also learn from the experts who are here as part of the panel. So, without further ado, my name is Amrita Dupelia. I'm the Associate Franchise Director for ASP, which stands for Advanced Sterilization Products. Currently a division of Johnson & Johnson. So my topic today is to obviously touch upon the COVID-19 world, which is new and scary and evolving rapidly for all of us, but then to focus more specifically on importance of instrument sterilization and how as a hospital or a healthcare facility we can help you be better equipped to manage this new world that we're in. Okay, so I think there's nothing new when we talk about hospital-acquired infections. This would be a burning concern on any healthcare facility's mind. Any of the different people working across the hospital do think about HAIs. Patients worry about HAIs, and we know based on studies which exist from over the years that the developing countries face a higher burden with respect to HAIs than some of the Western countries like the US and Europe. So when you look at specifically in India, and the data states here, about 25% of the patients who go into a hospital for any other ailment can possibly come out with a hospital-acquired infection of any kind. So this has always been a burning question and a concern on any healthcare professional that sees this day in and day out. Now, to add to that concern that healthcare professionals, patients, everybody already has, we've now entered a new world where there's another fear of specifically transmission of COVID-19, which sort of hit us out of nowhere, at least in India, around March time came earlier this year. So it's not just going in and thinking about possibility of an HAI, but now there are other measures that we always have to think about. Whether you're a staff member or a surgeon or any other form of a healthcare professional or a patient, you have to think about hand hygiene, wearing a mask, the 6 feet distance, the coughing and sneezing etiquette, the surface cleaning, all these different areas that you really have to now be more cognizant of or more mindful of, not just when you're in a hospital, but when you're anywhere. So this is, a new change, something that I think we're all learning in this new world. What would be the safety expectations now? I think as a patient, and I think all of us, in some shape or form have experiences either ourselves as a patient or as a caregiver. You want to walk into a safe environment when you're going to the hospital. You want to make sure you are safe and you're receiving quality treatment. So, especially at a time like this, I think any of us are wary to go into a hospital if you don't need to. All the elective surgery, everything has been put off because we just want to make sure that you are safe. But as a HCP or a healthcare professional, there's an even heavier reliance now on your staff, your OT staff, or your nurses, making sure the OT is ready in the right way, your instruments are ready in the right way. You really must be able to trust where your instruments are coming from. Are they safe? Are they sterile? I'm just going to adjust my camera because I don't know if you can see me. I hope this is better.
Yeah. We can see the presentation, but we can't see you, Amrita.
Oh, okay.
I think the camera is off.
It's actually on at my end. The light is on. Let me just let me try again. I'm just switching it off and switching it on again.
Okay, yeah, sure.
Let
We were
me
able to see you in the beginning, but in between it went off.
Yeah, I'm not sure because it's on at my end. If it's okay, can I continue with my presentation? Yeah.
Carry on.
So we'll figure out what's wrong later. So anyways, just going back to overall safety, I think there's expectations at both ends. Patients and HCPs are concerned every time they step into a hospital. So going from the larger hospital environment, I wanted to touch upon specifically based on data and studies that we've reviewed, what are some of the new concerns now that are coming specifically with respect to surgical instrument reprocessing, particularly in a pandemic situation. So it's becoming more and more critical um, to treat reusable medical devices as they are a potential source of transmission. It is a bigger concern now than even before. There's focus shift in hospitals on obviously making sure nothing spreads much more than before. But right now, the situation we are in is highly contagious, so you need to focus on making sure nothing really spreads. But in that process, it's also making the management of everything much more challenging. You're managing patient load, you're managing the reprocessing load or the readiness load for different cases at hospitals overall, are then getting overwhelmed with the situation. And what does that overwhelming factor lead to? It could actually increase the chance of human error as people are overworked or overwhelmed or just have too many different priorities that they have to take in mind. So we completely understand that there are a lot of different things on the minds of healthcare professionals, particularly right now. So just wanted to touch upon maybe a few things, a few measures that we can take, or we can, as a hospital, each of you can take to make sure that this is one thing you check off a box. You don't have to worry about this if there are a few measures that are put in place. So obviously preventing transmission by ensuring that any surgical instrument, particularly a critical device that comes in contact with a patient blood, is properly reprocessed and sterilized. The CSSD staff needs to be given time. I think that's usually where they're the most pressed. Either it's time or there's not enough of them to properly do the cleaning, the disinfection, the sterilization. There are different steps involved in the entire process of reprocessing instruments. So I know time is of the essence right now, but finding a way to balance that to make sure the workflow is really smooth and you can actually ensure that the instrument that's being used is not carrying anything that is contagious. Overall hospital leadership, and I know we have a lot of the hospital leaders here today, must help the doctors and nurses understand that this takes time. I know doctors' priorities are different and they are also pressed for time. But overall, we need to come together as a team to understand what are the priorities, what is going to take time, and what can move faster, and ensure that you are minimizing any sort of risk to not just patients, it's yourself, it's your staff, it's everybody. Eventually, it's risk to your families because there is something then, if it gets transmitted, you could be carrying back home to, elderly family members or young kids who we are always worried about. So, really wanting to minimize any of that with a few steps that we can take. And finally, I want to highlight, because this is some reason a common misconception that we just soak this in a chemical, in a high level disinfectant, this instrument for 20 minutes and it's sterilized. That is not the case. That is not the right way of sterilizing. It's only high level disinfected. It is not sterilized. So it will not take care of any risk that it could possibly pose on to the patient. So that was just one thing that I wanted to highlight here. So finally, I just wanted to talk very briefly about what is it that ASP, Advanced Sterilization Product, can offer in terms of technology. So I know a lot of the esteemed panelists and attendees today are already familiar with this technology, maybe different variants or different models of ASP Sterad, which is our low temperature plasma sterilizer that we've been offering in the market for over 20 years now. So this is used for reprocessing and sterilization of critical instruments before surgery. And depending on different sizes, you have size options, you have cycle options depending on the type of instrument that goes in. This ranges from anything from about half an hour reprocessing to about an hour reprocessing in terms of time. But then you are guaranteed a sterile instrument at the end of the process. This does more than sterilizing your instrument. It actually reduces workflow interruption. It actually helps you optimize the way the processes are run, both in the CSFD and the OT, and limit any chance of disruption or any loss of productivity. So it has a lot of more value-added benefits beyond just sterilizing an instrument. You have better compliance. It's all fully automated, integrated. You can go back at any time and check specific to a load whether in fact it was sterile, whether it passed the biological indicator test, and link it back also to the patient. So you can have these documented records even for your hospital audits or any sort of checks that need to be done. We've made it very simple, so you don't really have to train anybody to use it. It can be used very easily by anybody with maybe a 10-15 minutes or a demo, because you can see from the screen it's like an iPad setup, which or a smartphone setup, which a lot of people are very comfortable with. And being a strong brand, ASP has been in the market for over 30 years now. Globally, is the market leader when it comes to low temperature plasma sterilization. You can at least know that you're getting the best that's available. So something that ASP has got very recently amidst the pandemic, we understood obviously that reprocessing N95 masks at a certain point was critical because people were running short of these masks, and this was again leading to spread of infection. So this is just a recent update from a couple of months ago, where the FDA has actually issued an emergency use authorization to help you make sure that you can actually reprocess and decontaminate and sterilize N95 masks in a sterile machine. And finally, I just wanted to wrap up with mentioning what's beyond technology, right? So one is obviously the technology solution, but there's so much more we believe we can do to partner with your hospital, especially at a time like this where I'm sure you'll need us the most. So I just wanted to highlight a few things. There is obviously pressure on capex or capital investment upfront at this point. So we have introduced financing and leasing options for our technology, which can be used by any hospital. We've also got centers of excellence set up at hospitals, at key centers across the country, where we have the entire ecosystem involved installed. It's not just the machine, but the biological reader, the software on the computer, and everything talks to each other in a very seamless fashion. So we have that set up across the regions. We also offer expert advice and consultations and observations, where an expert in the field can come in and identify if there's any gap in the process and really suggest any areas of improvement for you. And finally, I think as ASP J&J, the thing that we do best is always training and education. We invest a lot of money in this area and we offer it at no cost to hospitals around the country. Train everybody on technology as well as, like I mentioned earlier, on process optimization, which is key today, so that your team is taken care of and you have enhanced sterilization and a better workflow overall. So that was sort of what I wanted to highlight. Some of the things we do a lot more, but I think these are things that could be very relevant to the current situation. We have 550 installations in India. It's a huge number, the maximum number of machines that our companies installed in India. And as you can see, it's with all the top names. I know a lot of you come from these hospitals today as well. So really, thank you for your partnership, for your time. We will continue to be here to help you and support you in any way during this pandemic. But I will now wrap up and be happy to take any questions if you have or later as we get a chance to connect. Thank you.
Sure. So hello. Am I audible to everyone?
Yes, I can
Yes,
hear
you're
you.
audible now.
Thanks, Amrita. I'm sorry, I was on mute and I was speaking. So thank you, Amrita. Thanks for an excellent presentation. And I welcome Dr. Tarang Gyanchandani. She is the CEO of Sri H.M. Reliance Foundation Hospital. And I also welcome Yatish Bahal. He's the Executive Director for Neti Healthcare and Research Private Limited. And any quick question for Amrita, any inputs on her presentation by any of the panelists before we start our panel discussion? Amrita, are you still here? You can.
Yes, I'm here and happy to take any questions.
Okay. Any feedback, Dr. Hari Prasad, Dr. Alok Rai, or Tarang, or Yatish. I think there are right now not any questions, Sabita, but we'll be happy to have you here with us for some time more. If you can still be here and join the panel. And so
Yes, I'll be around for the rest of the summit, and I'll sort out my camera in the meanwhile. Thank you very much for this opportunity.
excellent. Thank you, Amrita. So we are starting our session, which is the panel discussion on redefining healthcare sector in the post-pandemic world, and we have an eminent panel here. Let me just uh, read their names again so that audience who have joined late, they know who they are. So we have with us Dr. Alok Roy. He is the chairman and managing director of Medica Super Specialty Hospital, Kolkata. Welcome, sir. Thanks for joining us here.
Thank you very much.
Thank you and namaskar to you. And I welcome Dr. Hari Prasad, President Hospital Division, Apollo Hospitals. Welcome, Dr. Hari Prasad ji.
Thank you.
Thank you. And I welcome Dr. Tarang Gyan Chandani from she's the CEO of Sir H.N. Reliance Foundation Hospital, Mumbai. Welcome, Dr. Tarang. Thanks for joining.
Thanks very much. Thanks a lot.
Namaskar. And we have Yatish Vahal, Executive Director of Neti Healthcare. Thank you, Yatish, for joining us.
Thanks, Ravi.
Thank you. So we are going to talk about the healthcare sector in the post-pandemic world, and we are still in this pandemic situation. And I request each of the panelists to please give your initial comments on this emerging and evolving situation, and how is it affecting the healthcare sector, and how are you seeing the next few months. So requesting each of the panelists to speak for about 3 to 4 minutes each. And I also request each of us to please keep your mics on mute after you speak so that we reduce the background noise. So I will request Dr. Tarang to start, like give you a visual of the situation, please.
Right. So first of all, thank you very much for having me here. And it's really been a privilege to be a part of this platform once again. So as we see the way the pandemic is moving ahead, I don't think that there is any way we can see a respite coming before at least 6 months to a year. I think by that time we all will learn the new way of life, and we will learn to live with COVID, and we'll find ways and means to manage healthcare with COVID and make it a part of the way the healthcare is. And that's the only way I look at it, and that's the only way I think we have to move ahead with. We cannot have this continue to impact our healthcare service delivery beyond a point. Yes, there is we need to take precautions. Yes, we need to make sure that we need to protect our staff, protect other patients. But at the same time, we all have realized that most of the people who are affected by COVID also, they are not highly symptomatic, and the disease has its way, the way it is for any other viruses. Yes, if the infectivity is very high, but at the same time, as the virulence or the severity of the virus is not as what we have seen with the SARS. So I think the best way is to make it our friend and learn to be with it and deal with it. So there will be impact on healthcare, and there will be impact on all industries via alone healthcare. But the only way to deal with this, and I think humans always develop resiliency, and we have to move ahead. So according to me, the impacts will be there. We are all seeing a major impact on all the healthcare institutions, whether it is in our care delivery, whether it is in the footfalls, whether it is the morale of the people. But I think only way is that we need to change our point of view for everything. We will now need to come out of the regular way of looking at the hospital. It's how we change our mindsets, and I think that's the way to go. But so far, it's very difficult to say whether the impact will be 3 months, 6 months. I think most likely, most of us feel it will be at least 1 year plus. So that's from my end.
Okay. I think Joe used that let's deal it as a friend and let's learn to live with it is the message which I got from you. May I request Dr. Alok Rai to give your opinion on the situation?
Thank you, Mr. Ravi. Thanks for inviting me. It's a pleasure to be here in your seminar, which is watched with a lot of interest. Uh, when this pandemic came, none of us were prepared for it. None of us knew it. None of us knew how to handle this. So obviously, when unknown things come to you, you are scared and you are full of fear. That's how the entire community, doctors, everybody were scared. We were very, very worried how to deal with it. But we realized that between the disease and the society, the only people who are standing in between are us, healthcare workers. Of course, everybody is providing support like police and everybody else. But without doctors, this war cannot be fought. We are the frontline soldiers. When this realization dawned on us, we took a step forward and engaged the enemy. And today I'm very happy to say that, though at a serious professional loss, a serious financial loss, we all healthcare workers across the country in the private world are fighting this war along with the government and along with the public. Now we are ready and prepared. The last point which I like to mention as introduction is that we are changing constantly. We do not know how to deal with it. And as time passed, we realized hand washing, we realized a lot of corrections. We made a lot of infrastructural changes in the hospital. We completely changed the way air conditioning works in the system. We changed the way we work in the system. The problem with this disease is that, unlike many other disease, which doesn't affect doctors, only patients affected. Here, both sides can get affected. Hence, the precautions have to be both ways. Now, not just for the patient. We learned that. And now we have come to realize that this battle is going to last longer than we expected. And we are prepared for it. We are changing, learning as we are walking. As we say that you need to fly a plane and construct it while you're flying it. Thank you.
Thank you. Great inputs and thanks, Dr. Alok, for highlighting the role of doctors here. I think I think overall society and overall, like we all can see that governments are realizing the importance of hospitals and doctors big time, and every day we are reading steps around it. Uh, uh, may I request Dr. Hari Prasad to give your initial comments on the situation. Hari Prasad.
Yeah, good morning, and thank you very much for having me on this panel. One will be a little longer introduction. Ever since we started counting the number of COVID patients and the deaths due to COVID in India, more number of patients have died because of heart attacks, strokes, and cancers, and many other diseases in the country. Somehow COVID seems to have occupied everybody's mind, and that's become something which everybody seems to be talking about, forgetting the regular disease load in the country. And there is a reason for this. I would say that healthcare in this country has collapsed. The entire foundation has collapsed. And the reason being, nearly 80 to 85% of the healthcare in the country is actually provided by the private sector. And this 80 to 85%, which is the majority of the healthcare in the country, is not provided by the people sitting on the panel or the large network of hospitals or the large hospitals. All of us together probably constitute just 5% of the total healthcare provided by the private sector. Major part of the healthcare is provided by the single doctor sitting in his clinic in a periphery, or by a small 5-bedded, 10-bedded, 20-bedded nursing home in the periphery. Now, all these have shut shop. They're scared, as Alok said, and they're worried to open up. And this has actually led to a complete collapse of the foundation of healthcare in this country. And unless we get the confidence of these people back, unless we help them to restart, unless we help them to get over their fears and help them to start practicing with the precautions that need to be taken to keep themselves safe, to keep their colleagues and the healthcare workers safe, and to keep the patient safe, I don't think we will be ever able to come back to where we were before the COVID struck us. Then all the hospitals, the larger scale hospitals in the private sector, the occupancy went down to 20%, 30%, and some even lesser than that. We're just seeing it pick up. But this is because of the scare that was created in the public that the entire coronavirus is around in the hospitals in the country. But my personal opinion is healthcare providers, hospitals, doctors know a little more about the precautions about the virus, and they definitely take more precautions than any other place in the country. So a hospital is a safer environment than any other environment in the city or in the town or in the village. So people should not hesitate to come into the hospitals. And I would just end with a survey which was conducted by BCG recently. This is the most recent survey in terms of how to get the patients back into the hospitals and make sure that they have access to healthcare. It is not just COVID, it's about all the rest of the disease load in the country, including the NCDs, which are responsible for 80 to 90% of the deaths in the country. So the 5 or 6 factors which matter to the common people are: one is they're looking at technology and virtual care, which is becoming big and which is something which the people are looking for. The second thing they're expecting is no cancellations, and if there is a cancellation or a rescheduling, there should be a fine or a penalty paid by the hospital. And then the third thing, they're looking at COVID-19 testing for patients after treatment. And a lot of us, what we're doing is we're making sure that the patient is COVID-free when we are admitting. But what the patients are looking at is they want to get out of a hospital, and before they get out of the hospital, they want to know that they are COVID-free. They don't want to have waiting times in the hospital. They want to see improved infection control protocols, and they want to make sure that COVID-19 testing is done for the healthcare workers, and all of them are safe to be in the environment. And lastly, strict social distancing at the care site. So these are few factors that the patients are looking for to get back to the hospitals. So we will have to work on multiple fronts to get the private health sector and the healthcare back on track. One is to allay the fear amongst the common people, to deliver to their newer expectations for post-COVID, which I've just highlighted to you, and also to make sure that the doctors who are running the smaller clinics and hospitals get back to work with additional precautions, with confidence, and deliver what they were delivering so far. Tertiary healthcare cannot survive or sustain without the solid foundation of primary and secondary care, and that's the current problem today. Thank you.
Excellent input, sir, Hari Prasad, and for highlighting the role of primary and the secondary healthcare infrastructure. And we can see that all our bigger hospitals are overloaded with the COVID patients, but the bottom of the pyramid is lacking somewhere. Requesting our next speaker, our panelist, Yatish Bahal. to speak. And before I do that, requesting other speakers to please mute your phones, please. Dr. Hari Prasad. Yeah, yeah, yeah. So Yatish Vahal is the Executive Director of Nayati Healthcare and Research Private Limited. Yatish.
Yeah, hi Ravi, good to be back again.
Yes.
So the last time when we were around, we were just entered into the early COVID phase. And then the dialogue was that, as Dr. Prasad and Alok was also mentioning, there we were directed to not accept patients on elective basis. And we were seeing a scenario where there were not enough patients, and the OPDs and anything other than emergencies had been stopped. Today there is a reversal, I would say. While again unlock 1.0 is on, but still the confidence that some of the other speakers have pointed out is missing, and the volumes in the OPD and your electives coming in remain low. But at the other end, there is a huge spurt now in the cases, especially when you look at North Delhi, UP, and Maharashtra. So Garang would sort of be there siding with me, as well as would be Alok. In Delhi today, while the government directed us now to take over beds, unfortunately or fortunately, given the sheer size, all of us now in the hospital space, all the organized players, including, and I'm sure Hari will back me on that, we've all, even Apollo for that matter, we've now allocated more beds for COVID as opposed to non-COVID, because it's also a reality. Whilst again the mortality may be low, but as Alok also pointed out, it's highly, highly contagious. And therefore, now the steps that are being taken in especially with old centers, not the newly built ones which had segregated AHUs and positive and negative pressure areas, we've had to make provisions to allow a coexistence of both COVID and non-COVID, because A, the sheer volume, and secondly, the fact that it's going to be around for the next one or more than a year, and we have to coexist with it. So you have to segregate, and within the same facility now allow both to coexist. Take the learnings from Italy, where we don't allow the system to get overwhelmed, not allowed your non-COVID patients to become infected. What the study, BCG study, has also stressed upon, that there has to be a post-treatment COVID test prior to discharge, because the intent is that there should be enough safeguards in terms of infection safety protocols that are deployed in hospitals and facilities today in order to contain the spread of the disease. Is going up, and yet the reversibility is high. On maybe on the ventilator, if you were to go on, the mortality rates are higher, but still it is fairly treatable and better than some of the other ailments, especially SARS, etc. We've recently just yesterday discharged a 97-year-old patient from our center at Agra. We've got a direct hands-on experience. Agra being declared by the government as a completely dedicated center in the wake of the spurring numbers, and likewise in Delhi, Mathura, we are doing both COVID and non-COVID. So it's a evolving situation. A couple of 2 months ago, when the lockdown had started, we were still trying to grapple with times and see how do we remain afloat. Today, there's some better degree of idea. We are still toying and experimenting, but yes, additional safeguards have been put in place. And as Hari had pointed out, we are perhaps the safest zones to come into. Nobody is completely insulated against the spread of the contagion, but yes, there cannot be anyone else better prepared. Is costing us dearly, and which is why the primary and secondary players are suffering significantly, because whilst the organized players do still have some balance sheet available or some support or leverage, the unorganized husband-wife duo or partnership, proprietorship that was running for, they are not able to absorb these costs nor implement the infection protocols, which is a cost to us. And therefore, some sort of a support will have to be made available for them if the one wants the Indian healthcare sector to be really resilient, truly resilient to the onslaught of this pandemic. Ravi.
Excellent input, Satish. Thanks for highlighting the point about the numbers are rising dramatically, and the COVID beds are increasing and the non-COVID beds are decreasing in each hospital now. And Yatish, you have highlighted the various financial constraints which this situation is imposed on the private healthcare service provider, and especially the smaller ones who are not able to sustain. And Dr. Hari Prasad talked about that many have shut the shop for now due to the uh, uh, fear factor also. So uh, maybe discuss about some of the financial challenges in these situations. So may I request Dr. Alok Roy to talk about that for the hospitals, how it is straining the financial resources. Alok.
Thank you, Ravi. There are, as Hari has said, there are very clearly three defined sectors in healthcare delivery. One is up to 50 bed hospital, then 50 to 150 bed hospital, then 150 and above hospitals. Most of us are here in 150 and above hospitals, up to 300, 400 beds. All these baskets have different challenges. Primarily, the one who has a 50 bed, he's a one who has a personal pull. He's a doctor with his personal capability and he's still pulling patients. He is still getting good 40, 60, 70% of his beds are occupied. He was down and out in the beginning 1 month, but after people start coming back, especially non-COVID patients, they start coming back to him and they are doing reasonably well. Up to 50 to 150 have gone down, but not dramatically, because they are community-based hospitals. They may not have a personal pull, but because of the community based, they're still doing 40 to 50, 60% numbers and they are surviving with difficulty. The biggest hit has been 150 to 300 bed hospital, super specialty hospital, multi specialty hospital. They have lost out on numbers up to 80%, 85%. Somebody has 20% occupancy, somebody has got 25% occupancy, nobody has more than 30% occupancy. Because all non-COVID super specialty surgery or tertiary care surgery has come to virtually standstill, especially in lockdown. Now after lockdown is getting over, few are coming in. But now on 150 to 300 bed larger setup of hospital have a bigger challenge of dealing with COVID because they are also getting a lot of COVID patients who are not going to smaller hospitals. Because smaller hospital does not have a wherewithal of dealing with them, they know it, and also that they know that care will be better. And because community is scared, they are flocking to the best hospital. So financially, the maximum losses have been initially for a single doctor hospital or a small hospital. Now it is focused very much on large format hospital. Some of us have lost in 3 months almost entire EBITDA for the year is wiped out. That means our cash flow is severely compromised. It's not just loss of business because we have to redefine the business in terms of infrastructure changes, in terms of PPE, sanitization, distance, not having enough people in the OPD. We have to control the OPD numbers. As a result of all that, there has been a serious financial losses. I don't see any that it will improve in next 15, 20 days or 1 month. Maybe as in the initially has been said by one of the panelists, probably in 2, 3 months start improving. But we have no clarity at this point of time. We are like flying a plane in the cloud. We can't see where we are going. Yes, we know that there are the difficulties, and so let's face it, we are all bracing for a serious financial impact, and there has been no help from any sector so far. There has been some help from the government, which came in the form of getting our old dues. No new support from any quarter has come. So every private provider is on his own in this country to fend in this difficult time. Over to you, Ravi.
Uh, Great inputs, Dr. Alok. You highlighted very clearly the challenges at each level of the hospital. Uh, may I request Dr. Tarang to talk about the financial challenges for hospitals in these situations?
So, as has been rightly mentioned, I think all of us are definitely facing the financial crisis. I think there is a slightly difference in the outlook that we all are having from the various geographical locations that we are operating from. So, while I think the heat is picking up in Delhi and other states. Bombay itself right now is in the heat and has been in this situation for a long time. So I think what we have seen here is that yes, we saw the worst part of it, where we saw that most of the beds were getting moved to COVID. But now I think slowly, probably is it because of the resilience which the city always had, or whatever. But we see people and the institutions coming forwards, and then uh, the financial losses, of course, are it's a double edged sword for all of us, because on one side our revenue lines have completely got flattened, and on the other side the costs have increased, because you have to take care of your people to keep up their motivation level, to support them during this crisis. You have to take care of the PPE. You have to take care of the infrastructure changes which are required to manage even a normal fever patient, because initially when a patient comes with fever, you are not sure whether it is a COVID or a non-COVID. Till that time, you need a specific kind of infrastructure. You need a negative pressure isolation. So for all those things, the costs have suddenly increased a lot. The simple levers on which most of the CEOs usually function, which includes the average length of stay, they all have gone, or RPOP for that matter, they all have gone for a toss. So we'll have to all, over a period of time, learn to redefine everything. A lot of innovation will be required. A lot of change in the thought process will be required to create now the new lines, so that because at the end of the day, we have to provide safe healthcare. We have to provide the best for the patients, but at the same time, we have to manage our costs also. We have to manage our sustainability also. So either ways, I think there has been a hit. But as I said, in Mumbai, from what I see, it's not. It's getting, even if I see a 1% change in moving towards better, I think we are 1% better than what we were a few weeks back, in our attempt to move back to the normal. Because there are certain things which will happen only in hospital, and as we rightly heard, that right now the people have to be just assured that it is safest. The hospitals are taking the maximum precautions, and they are the safest place to be in. So with this, I think there will be financial burden. It will last for a very long time. But I still feel that healthcare industry will be one of those industries which will be bouncing back before other industries, because the other industries right now are just going through the crisis. They will take a very, very long time to come out of the economic crisis. But hospitals, given the nature of the fact that we provide healthcare, they will be able to come back. But yes, it will be a long process, and it will need a lot of thought process to find out ways and means to reduce the cost, to still increase the revenue, so that your EBITDAs are able to just manage. But yes, right now, I think everybody has to find ways and means to give a safe, affordable healthcare, and at the same time ensure that we have the requisite changes done in our systems to prevent the patients from the infection. And at the same time, start thinking about alternative revenue lines strategically. The dependence on technology again will be high, but again, technology comes with its own price. So that means another dip into the finances. So it's a thin rope we are all walking on, and I think at this stage it is a little premature to come out with a thought process on how to increase. But yes, the line of thinking has to be towards innovation.
Great inputs. Thanks for highlighting the various aspects of the challenges, and thanks for highlighting that health care will be perhaps recovering faster than other sectors. Uh, may I request Dr. Hari Prasad to talk about how long is the recovery path financially for our hospitals?
I'm very tempted to say this for a country, roti, kapda, or makan, and after that it is healthcare. And in India, private healthcare plays a major role, and is in fact providing almost, as I said earlier, 80% of the healthcare. So the well-being of the private health sector is critical for the country, but nobody seems to be bothering about it. Everybody seems to be looking at private healthcare as somebody who is making a lot of money, may have a lot deep pockets, and need to shell out money to help the government in this crisis. Now, the private sector is not looking. I can talk on behalf of the entire sector because I've been listening to all of them. I've been talking to many of them. The private sector is not looking at profiteering in the COVID crisis. All we are saying is, don't kill us further by your pricing and the structures that you're creating to handle the COVID. If we break even, we are more than happy to give all our beds and get fully involved. We have a responsibility towards COVID, and we will fulfill that responsibility to the fullest extent. But what is happening today on the financial front is they are expecting us to deliver more for less. That is, deliver better care, deliver care with better infection control measures, all of which cost more money at a lesser cost. Now, this doesn't add up somewhere. So, unless we develop a synergy between the different stakeholders, it's not going to work out. We're never going to meet at a common point unless all the stakeholders come together and create a win-win situation for everybody. The country needs the private sector. That is understood and acknowledged by everybody, including the government. But after that, what? How do we support the private sector to come back? It has taken a beating. It's taken a huge beating. And unless the 4 Ps come together, and we are not going to be able to sustain or come back as quickly as we should come back. And when I say the 4 Ps, it is the public, private, and people participation, which is required to make sure that all the stakeholders get what they want, and it create a model which is sustainable. And if this happens, then I suspect that it will take a minimum of 6 months for us to start breaking even, and after that another year to reach the levels of the pre-COVID times. But I think there's a huge amount of support that is required from the government. But unfortunately, we haven't received much. And although I must appreciate the fact that the government has been talking to us, taking a lot of inputs, listening very patiently to us, but unfortunately, nothing has come out in terms of action. And we are looking for support from from the government side on multiple fronts. And more importantly, we are part of the war against COVID, and all we are asking is to help us be partners in the COVID war with a break even and not pushing us deeper into a financial crisis. Ravi?
Yeah, excellent inputs, Dr. Hari, and thanks for highlighting that issue of the government rates, which I think are not working out for many hospitals. Requesting Yatish to please talk about what support you think that the government can provide, and requesting other panelists to please mute your phones, please. Yeah, Yatish.
Well, Ravi, if you were to look at what measures the government have taken, they have basically aided our cash flows. So, in terms of the receivables that they've ordered, that if you're MSME registered, well, it doesn't cover most of us because we don't come into that criteria. So we are not covered, and therefore the 45-day receivable period doesn't fit in. But having said so, okay, it's good for a larger audience. But even then, what are you doing? The money that was due to us or that's been stuck in the system, you've given that to us. So, okay, we'll tide over payment of salaries, vendors, we'll push some of the creditors, that's fine. But what has happened is you've stopped us from accepting business in the initial few days. Now, because of the entire paranoia that's surrounded around healthcare, one is a bit scared. People who are vulnerable, they don't want to come into an hospital fearing they may get a hospital-acquired infection. So, the flows are low. Yes, the sector is bound to be resilient and would be one of the first to be back on track because, as Hari said, roti, kapda, makan, and healthcare. Yes, we'll be back, but what happens to the intermittent period? At best, all hospitals would, their EBITDA was a month's revenue at best, post interest or whatever that was getting added to the reserves. You got us to be virtually out of business for 2.5, 3 months, and it's not as if the fourth month unlock one and we'll be full. So the revenue is going to take a fair bit of time. It's a long journey. It's as good as commissioning a greenfield facility today. We don't know how much time will it take to sort of reach that penultimate capacity. We don't have the liberty of some of the other industries where they've gone in for a shutdown, where the labor has gone back. We, as the emergent and emergency service providers, are required to have a full setup available. It requires a cost. It's not just supported by one doctor, it's the team that works. So we have fixed costs, and currently that fixed costs are not getting covered at all. Likewise, there is, and we were doing this, Alok has been there on the FICCI committee, wherein we are saying to the insurers today, see, one of the basic problems that we are facing is, in addition to whatever capex modifications that all of us are doing, there is a regular operating cost of the PPEs. Earlier, the consumables would get disallowed, but in terms of the overall bill, it didn't matter much, and we could absorb it. Or even if they were charged as a non-payable to the patient, they would happily do it because it wasn't a significant figure. Today, largely, especially the government panels, they've very categorically stated that the PPs, etc., would not be charged to the patient. So where do we charge it to? Because the argument is that, well, okay, aren't hospitals supposed to maintain hygiene? Yes, we are. But the level of hygiene or infection control that is there or was in a OT, you cannot have it across the facility. Today, you have had to ensure those sort of setups around because to know the degree of severity and the contagious element of the virus. So all of that has a significant element of cost. It requires the panel as well as the TPS to realize that there is a significant upswing in the form of the disposables and the consumables, which need to be factored into either in their premium. When the actually needs to take that into account, all these years when those costs weren't so high and the regular premiums were coming in, they have to build that in, or they build in an extra premium for COVID. Because the patient, we are treating them with the best of our ability. We are not compromising on the quality. So why is it that we should be asked to compromise on the price? And that is one of the major reasons the basic centers are not able to afford this, because if they don't take these measures and people expect them to take these measures, they can't sort of sustain the operations. If they don't, there is a spread. There are new policies that are coming in from the government. Delhi, for instance, there is a mandatory directive now that all hospitals more than 50 beds have to reserve 20% beds for COVID. Not all hospitals have a chest physician or a pulmonologist attached with them. What do you do with such setups? How will they manage COVID? A multi-speciality can still bring in, but where are they supposed to manage? And the reason those beds are not getting filled is that they're just going to give you an isolation. Tomorrow, if the case complicates and you are required to intubate someone, they're supposed to refer that patient out, and there are no beds. Where are you supposed to refer those patients out? And that is why people like us, okay, we have right now a spare capacity, and again, we don't want to make money, and we've opened ourselves up. Okay, we see the plight of the people. and that's what's happening. But at least then don't kill us on the cost front and say, no, you have to do it at a certain rate. Either you support us, because, it's not just about the treatment also, Ravi. The clinician who's supposed to treat that patient typically shouldn't be going home. We are providing them alternate stay arrangements, because otherwise the people back home are stand exposed. Likewise, when the patient is about to get discharged, there is a certain degree of quarantine period meant for the clinician and the entire team. So virtually for treating the same number of patients in the hospital, you require 1.7 times the staff, if not twice. So where is that cost going to get absorbed? Because the revenue is not that much. There is not that much billing that's going to happen. Costs definitely are piling up. So the gap is there. By giving us our TDS in advance, or which is already due to us and should have got processed, but you've done it only for individuals with refunds up to 5 lakhs. What happens to corporate like us? So there are no support to that extent. You've given us our receivables. What about the immediate billing? There's no clarity on that. Is there a SOP available? There's an entire industry. 80% of India's health is done by private sector. So, some sort of a support. We are also extending this over. We can't lay off our staff. They also need the requisite, resources to have a day-to-day functioning. They're there on the front line. They're risking their lives. So they need the support. The hospital also doesn't have an endless offer. At best, we'll have to go back to our reserves. But what about those who don't have the liberty of such reserves? They will get wiped out completely. So some sort of a support, a financial through aid and not a loan, because the loan has to be refunded. Some sort of a aid package for the healthcare sector has to be worked out. That is need of the hour, because without the healthcare sector, there is no way that you can fund this pandemic and fight this pandemic. Some corporates are using their CSR arms and they may be well funded. But most of the others like us are private limited companies, where we generate the money from the business or the services that we extend. And that is what keeps us sustained. Today, the sustainability is a challenge. And therefore, via this channel again, and we've used all the other forums, we are representing there has to be a monetary package for the healthcare sector. It's need of the hour and very much imminent. Thanks.
Yes.
Ravi, if I can just add on to what was just said. We are living in a paradoxical world. If you look at, at least in Delhi, 20% of the beds are reserved for COVID patients. But if you look at Maharashtra, 80% of the beds are reserved for the government. And what happens in this 80% beds is, it is not just COVID. Even non-COVID patients, the rates are regulated. So even if you have a CABG patient, there's a package which is described and you're expected to treat at that package. So what are you doing with the private healthcare? How is it going to sustain if you're not going to reserve 80% of the beds and then also have price caps on the non-COVID patients? We're not just going to sustain. There's going to be a situation where we would not be able to treat COVID, which is the need of the hour. The private sector has to be involved in treating COVID. There's no go for the country. The acute care beds, the majority of acute care beds are in this country, and as time goes by, we're going to see more and more acute cases coming up. And the private sector is the place which has to provide the care. And if we are going to kill the private sector with policies like this, I think it's going to be the people who are going to suffer more than anything else. So I think policy making and decision making is, because it is on both the central and the state lists, concurrent lists. We have regulations coming from the center, we have regulations coming from each state, and we really don't know what is happening. There's just so many regulations coming, we don't know what's happening.
Sure. I'm requesting Dr. Tarang to speak because I understand she has a meeting, and so give your remarks, Tarang, on this way out from a what is the policy support I think the government should be providing, and how do you deal with this situation? Yeah.
Thank you, Ravi.
So thanks, Ravi. So I'm hearing my other fellow colleagues. I completely, we are all in the same boat. But I think at some point of time we have also the government also has a very difficult task at hand. It's not only our country, it's most of the countries where the entire healthcare system has been strained. It's also the whole, many countries' government have collapsed. And it's not, their job is also tough. Tough because they have to manage the expectations of the public also. The public is expecting that everything should be free because the levels of anxiety and the levels of stress amongst the people is so high that everybody is reacting in a very different situation. One of the reasons that most of the countries have opened lockdown is also not because of anything to do much with COVID or controlling COVID, because we all know that the peak usually comes in the countries after the lockdowns are opened. Most of the countries at least have shown that trend. But the lockdowns have been opened because otherwise it would lead to a law and order situation. People will be out of jobs. So while I agree, all of us are in a very, very difficult state, but we have to also agree it's like a vicious cycle. The government has to manage the expectations of the people. The people are getting probably cut in the job, salary cuts. So they are finding difficult to fund the healthcare. So it's a vicious cycle. Usually, though, countries where the reserves are very high, probably they can pump in lots in the private healthcare, in the government healthcare. But ours is a country where the policymakers are also walking on a very fine line. Nonetheless, I think the best way I personally feel to make these policies, to give a suggestion to all those who are in the position to make the policies, is that, of course, we all know in private healthcare sector also, there are times where things happen in hospitals which are not acceptable to people, which if we also sit and audit are not acceptable to us also, that this should not have happened. So in such a situation, we need to have a voice in the policy making decisions where we can, some of us whose voice can be heard, where we are fair to the people also and understand the plight of the government also. Ours is a developing nation. It's very, I know we all would love and want that the government has to fund in the private sector. But where the government is also, we have to see the funding of the government also, with all the income sectors going at all-time low. The funding in the government also has to be there to take care of the common man who will probably after a few months will not have job, will not have food to feed his family. The farmers, our agricultural part of our country, who will take care of them? So I'm sure the policymakers also have their share of plight. But at the same time, I think I completely agree. We need to have some fair policies. We need to have, may not have caps, like for example, 80% reservation for government rates. But we need to look, even if we are having those caps, we need to have a fair cap. The cap is not for us not to earn. The cap is to ensure that there is a standardized costing done. It's not that every hospital, one hospital can charge 2 lakhs, the other can charge 20 lakhs for the same thing. Now, in this time of crisis, obviously, when people are not able to earn money to feed their homes, how will they be able to absorb such a diverse pricing from healthcare sector? So there can be a standardization of pricing. I always see it as standardization because there are the countries I have been and I've worked, like country like Singapore, there is a standardized pricing. No hospital can charge beyond a particular range. So there has to be some way of standardizing the price so that it is fair. The hospitals can sustain themselves, because at this point of time, sustenance should be the main goal. And I think for most of us, it is the main goal. At the same time, it should look fair to the common man also, because we need to understand their crisis also. So the policymakers need to have inputs from the private healthcare sector. There should be the policies need to be made on data. The billing, for example, if CABG is done, we can take the billing data of 6 hospitals, private hospitals, 16 hospitals, and see what is the average billing. So it's when we say that we are all providing the best of the healthcare, quality healthcare, then the billing also, if we are so proud of the fact that we all provide great infrastructure, we provide the great infection control mechanism, we provide the best of the doctors, then our bills cannot range so there should not be such a big variation in the billing. And if there is a variation, if there is any standardized structure, of course, with all our inputs, which can bring about a fair deal for everybody, I think that's the right way of making the policy. At least that is what I have learned in my experience at Ministry of Health of Singapore, where you make policies, but it is fair to all. But that job is not easy. It's definitely, I think the most difficult part right now is of the government to play this balancing role. I know the certain policies are harsh, certain policies we can do well, but I think the best way is standardization will have to happen. I think whether all of us accept it or I think there is no option of not accepting. It is either accepting it or accepting it with retaliation and with angst. But we will have to accept some degree of standardization in our pricing. It will continue to hit our revenues, but at least it will open up, it will at least provide some way to open up the healthcare to the common man. Because if today, as a patient, I don't feel there is a difference in the pricing of any hospital in this area, I can go to any hospital and I will go and access healthcare. Right now is that like we are all again going back to kindergarten level of healthcare. We will have to start teaching people to coming back to hospital. And at that point of time, when they're already vulnerable, mentally unstable, they have had casualties in their house, family, neighborhood, I think we'll have to give the common man also that ease of comfort to enter any private hospital without worrying about variation in prices, at least of the key packages. But yes, there has to be fair deal given to the private hospital. It's not that they should be asked that, okay, you have put this rupees 500 charges for what? When you are saying that 500 is towards the infection control. People should also be made and educated that yes, if a doctor is treating you, he is bound to wear a PPE. The PPE actually costs this, but if the hospital is appropriating it, the cost, and putting a small amount of it, then it has to be accepted because it is for your own safety. Because tomorrow, if that healthcare worker is infected, if he's wearing PPE, you will be protected. So I think some degree of education, some degree of involvement of the private sector, and making the policy decisions in the interest of people, so that people as well as the provider, and so public provider, both are not only they participate, but they are both comfortable. But yes, I think lastly, this is not the time where all of us will get any respite by any kind of blaming to the government. We'll have to find a way along the government and together with the government only for our interest as well as the interest of a common man.
Sure. Great point about what are the challenges for the government itself in this situation, and requesting Dr. Alok Roy to give your, I think, concluding remarks of this session. Almost we are reaching the end of the session. Alok ji.
Thank you, Mr. Ravi. We all have said the same thing, that these are difficult times and we are going through really bad times. We have no money. We are scared. We have invested on infrastructure. We have invested on training. and we are facing very uncertain future. I would like to say at this point of time two things. First, the government, what government can do. At this point of time, if government can come up like what they have done in MSME, some kind of soft loan to the hospitals where it can take care of their cash flows, as Mr. Wahal had said in the beginning, that would help a lot of private hospitals across the country, which are very important for this fight. That to manage the COVID, we need private sector, little bit of some cash coming from the government, not as a freebie, as a soft loan to be taken back in 2 years, 3 years, would go a long way in sustaining the private hospitals, number one. Number two, I would like to say that the private hospital has to come to their core efficiency. They have to come to their core expertise. Like we are running a one in one place 500 hospital. Now 500 bed hospital which was doing a lot of things, a lot of profitable, non-profitable things. All those non-profitable things must be stripped off, must be shaped off. We must come to our core strength and do that very efficiently. That will bring the cost down. That will maximize our revenue, our efficiency. That will maximize our ability to deliver both in terms of public good, private good, fiscally good. All these three baskets will be addressed. So I think with that, we would like to say that time to be scared is over. Time to get ready and face this monster head on and do it with a full preparation and best arms you have in your sling. Thank you very much.
Excellent points, Dr. Alok, and I will I will request Dr. Hari Prasad to close the panel and with your remarks. Dr. Hari Prasad.
Yeah, thank you, and it's been a wonderful panel, and we've spoken about almost everything in healthcare. I just wanted to say, it's always easy to complain and say things difficult, what the difficulties are, but it is always important to come up with solutions. And I think the solution is very simple. Private healthcare grew on its own. Private healthcare was successful because of the least amount of interference in terms of multiple factors involving tariffing, pricing structures, and stuff like that. So what we would request the government to do is to leave the private healthcare alone. Private healthcare is responsible enough to respond to the pandemic, make COVID a notifiable disease, set a fair price tariff for COVID, and then leave the private health sector alone. We will manage it. And the second thing is, to replying to my co-panelists, I think it is not possible to standardize the tariff cards for all the hospitals simply because of the multiple variables that go into actually starting a hospital and operating a hospital, because there is a cost of capital, and the cost of capital of different hospitals varies, and the expected returns varies from different hospitals. The operational efficiencies, the operational costs, the size of the hospital, the multiple variable factors. So I don't think it is very appropriate to say that we would standardize the cost of a procedure across all segments of all the hospital, because it's not possible. Financially not possible, and it is not something which is going to happen. So all I'm requesting the government is fix a fair tariff for the COVID patients, and we are there to respond. We will treat any number of patients that come to us, and we will respond to the crisis. But leave the private sector alone. Don't start putting caps on the other non-COVID treatments, or reserving beds, or reserving unnecessary beds which are kept vacant for nothing. So we are a very resilient sector. We will come back, but only thing we request is leave us alone, and we'll help you, and we will help ourselves.
Great. One line message both from Yatish and Tarang. Yatish, summarizing one line, conclusions, please.
Well, we are there to support the government, and would want an equal amount of cooperation from there. And as Arifai had also said, allow us to function in our own domain. One additional point, we've also pointed this out before the healthcare group, and that is something important. There's a lot of migration of nursing that has just got on. These days, we need to retain them and not allow this to go on, because we would be requiring this manpower. The 50, 100 beds which are not functional need to be back on track. And if this drain is allowed to happen, we are going to face a severe challenge. So via this panel again and this portal, we'd like to appeal to the government to take in the steps and not allow the drain to happen for the moment. We need them back home, especially the trained ones, the ICU ones.
Yes, very important point. Closing remarks, Dr. Tarang, one line or two line comments to close this.
Okay, so from my side, just from where I started, I think all of us need to focus on, most importantly, to move ahead. There is no way we can now, it's a war. And in a war, people will have to work together, aligned. And if in a situation of war, we can't have all the soldiers marching in different direction. So if we consider government as the general of the war, then all the soldiers have to be aligned with the government. You can't take it as any other situation. In the normal scenario, yes, things are different, but this is not a situation where we need to react, because otherwise all of us will collapse together. So we need to be aligned, we need to be together, we need to be fair to each other, and at the same time we need to be innovative enough to look at what is our new normal and where we should move towards as a part of our new normal, whether it is in terms of how to manage our financials, whether it is in how to manage our people, and whether it is how to manage our entire existence. So I'm sure there is only one way. The way is collaboration, and way is working together. Nobody will listen to us at this point of time what we want. It is what the country wants. That's it.
Great. Excellent point. Collaboration is the key. Dr. Alok, one line summary remarks. Dr. Alok.
Yes, sir. Yeah. I mean, everybody has said the same thing. I think this pandemic is something which we have not seen ever in our life. Let's get on to the bandwagon. And as Hari has said, whether private has always survived, but today it is not survival of the hospital, survival of the world and the community at large. Let's all get together and beat it up. Thank you very much.
Thank you. So
thank you so much, Mr. Ravi. Thanks all the fellow panelists, and
Thanks.
it was a great exchange of ideas. Good.
Excellent inputs, and thank you, Dr. Tarang, Dr. Alok Roy, Dr. Hari Prasad, Dr. Yatish. Namaskar to you. Thank you so much.
Namaskar. Thank you.
Thank you.
भारत एक युवा देश है। विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना रुतबा खड़ा किया है और भारत इसके बाद के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये मैं हमेशा कहता आया हूँ, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया फुटबॉल। भारत एक युवा देश है। विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बाद के लिए गर्व करता है। दुनिया में हम बात कर सकते हैं और ये मेरा साथ मैं हमेशा कहता है आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया की।
Welcome everyone. Welcome in the second session of this Health Innovation Summit, and I'm requesting all the speakers to kindly mute your phones, please, so that we can reduce the background noise. Yes. So I welcome all of our speakers for our session. It's how virtual care and telehealth, teleradiology are redefining the healthcare system. I am Ravi Gupta. I am editor-in-chief of this magazine eHealth, which is a 15-year-old magazine and focusing on IT in health and health innovations. And I am requesting Dr. Naresh, who is the CIO of KIMS Hospital, Hyderabad, to be moderating the session. Welcome, Dr. Naresh. Thanks for joining us. Please take over the session, Naresh.
Thanks, Dr. Ravi. Thanks for the opportunity. Good afternoon, everyone. I'm Dr. Naresh from KIMS Hospitals, Hyderabad. We welcome you all for a wonderful session today afternoon. The title is very apt. Before I start, I would like to thank the organizers for arranging such wonderful session. During this COVID-19 pandemic attack, I think the role of technology has improved quite a bit. And all the people who are on this panel are the ones who are running the show as far as the technology and delivery of healthcare is concerned. So the topic for this session is how is virtual care and telehealth, teleradiology are redefining the healthcare system. Very apt title, I should say. To discuss further, we have quite a few distinguished panelists today afternoon. To start off with, we have Mr. Nandakishore Domne, who is the Vice President for Information Technology and CIO Manipal Health Enterprises from Bengaluru. Mr. Abdullah Salim, who's a Group CIO of Omni Hospitals in Hyderabad. Dr. Bharat Gadhavi, CEO and Regional Director, HCG Enterprises from Gujarat. And Mr. Prashant Singh, who's a Director of Information Technology and CIO from Max Healthcare. I welcome all the panelists.
Thank you. Thank you very much.
Thank you. Thanks. So let's start. I think, as I said, it's a very apt title for us to discuss. So first, one of the ways in which I've seen is that once COVID-19 struck India, way back in February or March of 2020, I think every healthcare enterprise, every hospital has, gone into a chaotic situation because we didn't know what was hitting us, what is a way out for such situation, when does all this end? Hopefully it ends pretty soon. So one of the ways in which we have seen is that role of technology has come to the fore like it has done all the time. So to take this further, I would request Mr. Nandakishore to just explain us or share his thoughts in terms of how COVID-19 has affected the whole delivery of healthcare in India and what has changed in hospitals from his perspective. Mr. Nandakishore? Nandakishore, can you hear us? Nandkishore, can you hear us? I think that's
Dr. Naresh, I think you can start with somebody else.
Yeah, that's what I was thinking. Take it.
So I can start. There's no problem, Naresh.
Yeah, Dr. Bharat Gadavi, please go ahead.
So COVID-19 across the world has really changed things completely. And going forward, because there is a physical distancing that has to be maintained, it is going to change the way we live, the way we practice, the way we take care of the patients in the hospitals. And it is not going to go away soon. It's going to be with us for many months to come. And such pandemics will keep coming because of the changes that we are bringing to the environment. So when we discuss about this pandemic, the major changes because of this the physical distancing, we will not be able to uh, remain in close contact with the patients for a longer time. We call it as clinical distancing. The guidelines are, if you are nearer to the patient for lesser than 6 feet for more than 15 minutes, your chances of catching the infection are comparatively very high. So first thing is, you will have to minimize the time that you are spending with the patient. Now, for that to happen, you will have to use the technology. You will have to make sure that you are having devices which can monitor the patient from a distance. Some of the key things that we are saying, we are still not been able to, like when I talk about the thermal scanners, you have to keep them at a distance of 5 to 15 centimeter, which is actually a very near distance, and you can easily catch infection. The chances are almost 2% of catching a COVID infection. So we'll have to start with good thermal screeners, which you do not require to handheld. You can just have a gate, something when the patient comes in, the temperature is measured, and somebody who is sitting 6 feet can tell whether the patient requires any further management. Can he be allowed inside the premises or not? So we have to start from there. Better thermal screeners, which will give us proper reading even when we are away. That is one area. We will, as we discuss further in the discussion, we'll come to know so many other areas where we need improvement, where we need innovation, where we need the help of technology. Remote monitoring, specifically pulse oximetry, people who are staying at home. COVID is a disease where the oxygen saturation comes down, and when it starts coming down, you need some specific tests to find out whether there is a cytokine storm or not, and should we shift the patient to the ICU. So remote monitoring, when the patient is in home isolation or even is in room, if we can devise some monitor where it is cheaper also. There are monitors available, central as parameter monitors, where you can get it from the nurse station. But even non-costly devices like finger pulse oximetry, if the reading can be transmitted at a distance, it will be much better and it will be much faster to take care of that patient. So these are the technologies we are talking about, where we need more innovation, where we will require a great leap in terms of changing the technology. Thanks.
Sure. Thanks, Dr. Bharat. Wonderful insight. Do you have Nandkishore online now? Nandkishore, can you hear us?
Yeah, I can.
Okay, wonderful.
Yeah.
Welcome to the session.
Can you guys hear me?
We can hear you.
Okay.
Yeah. Welcome to the session.
So I have switched mobile phone now.
Okay. No problem. So can you share your thoughts in terms of how COVID-19 has affected the whole delivery of healthcare in India, and what has changed in Manipal and what you guys have done?
Sure. So let me just first of all, begin with the impact of this COVID and the challenges, and also a lot of opportunities which have actually emerged out of this pandemic situation globally. We can largely see that impact, first of all, on the financial markets. I mean, each one of us, we are also an investor on an individual basis. And you can see how there was a complete crash of the entire financial market, not only the healthcare, but also a lot of other, sectors. So that's one clearly visible impact. And we don't know how long and how much time this is going to take further. But as an estimate, probably it will take another, 7 to 8 months to maybe come to a pre-COVID situation. So that's one, component of this. The second part of this is that if you come to the healthcare segment, this is definitely a very, very, very unprecedented global pandemic, right, which has come to the different countries. And we are no exception. Having said that, what happens is that if you see in particular, when this started spreading and India had the first lockdown, right, immediately the services like metros and the transport systems, etc., they were closed. Okay. So once you close the transport system and once you ask people to stay at home because this infection was spreading very fast, definitely the major impact was there onto the healthcare industry because patients stopped coming to hospital, right? So when patient stops coming to hospital and we have an impact on, let's say, the outpatient services, the inpatient services, the pharmacy sale, you have the lab stuff there, your health check as one domain. So barring the emergency services, every other services was severely impacted. Okay, that's another major impact onto the healthcare industry. While the footfall and revenue stopped coming, but there had been a fixed cost which was anyways going, right? So we had a challenge in terms of not only the footfall, but also how do we deal with the fixed costs. So fixed cost was one major bothering factor, and for which, if you consider Manipal-like organization, we approached and we contacted our suppliers. We requested them to kind of give us some discounts or waivers on the recurring payments, etc. So we tried to do something of that nature, and we were successful in handling to some extent. I will not say that it compensated the entire losses, okay, which we had incurred so far, and incurring those losses. So that was another component, which is a fixed cost. Now, third component, the supply chain part of it. Now we have to still run the hospital, we have to still run the facility. Doctors were needing the mask, they were needing the ventilators, they were needing the various other infrastructures. So we were not really prepared, or we are not ready for that kind of setup. For example, there was shortage of the masks. So we had to really struggle to get those masks. And having said that, there is a situation that in the entire support system, support staff is not coming to office. They are at home. Being at home, they still have to ensure that I am able to provide, I am able to channelize my supplies to the hospital so that hospital can run the normal operations, right? So the entire support staff being at home, because there was a complete lockdown, we were not supposed to go to office. All of us know that, right? So while we had to enable work from home kind of system for all our employees who were supposed to provide those services sitting at their home. So that was anyways one challenge, which was a technical challenge. But I would say that was a manageable challenge. Okay, like we had given the VPN to other people who were supposed to work from home and provide services, because hospital has to run the operations. Even if you get one patient, two patient, 20 patient, the operations still run. So we will need the raw material, we'll need the supplies to be there, we'll need a lot of other systems in place. So purchase department, finance department, IT department, marketing department, all of them are sitting at home, and we kind of enable them to provide the services sitting at home. So that was one aspect of it. Supplier, now they were finding it so difficult that even if there is a supply available, how do we send it to Manipal Hospital and the branches? Because the transport system was not right. So other than ambulance, I don't think there was kind of permission for other vehicles to ply. Then you have to go to the police authorities, take the permission, take the passes. So this is a very kind of is a situation wherein you have all those limitations, all those constraints, but you have to make sure that you are able to run your operation smoothly. So while I covered the cost component, the supply chain component, the work from home component, which was a challenge, now if you come to the important component, which is more of how do we still engage with the patients who don't want to come to hospital, but then they're ready for a video consult kind of environment. Okay. So what we have done in Manipal is that exactly within 7 days, the IT team at Manipal, I mean, I must appreciate the efforts. Within exactly 7 days, they enabled the video consult for the patient. And we were able to do almost between 250 to 350 kind of video consultations every day. While this is not a substitute to my normal footfall, which is roughly around, let's say, in my flagship hospital, 1,800 patients on a peak day like Saturday. Okay, getting 200 video consultations nowhere, substitute. But what we were able to do is at least we found this opportunity to enable the video consult, and also we could see a lot of behavioral change with the clinicians, the doctors. They were ready to do video consults. So while the consumer is always ready for a technology, I mean, although they are not as prepared as they are prepared for many other technical gadgets and apps, but patients in India, by and large, they like more of a personal touch, personally visiting doctors and all that. But then this pandemic, I have seen there was a major behavioral change at the provider side as well as the consumer side. And we were able to use this kind of, the VC consult, okay, not only for doing a video consultation, but the entire workflow, which starts right from the appointment, in fact, the registration, appointment for video consult, make the payment, do the video consult. We used to send a link to the patient, his WhatsApp number and all that. And we gave them the option of Zoom and Microsoft Teams. We had signed up a contract with them. Do the consultation, upload the prescription to his WhatsApp number, then integrate with the home care department. They will call them for the pharmacy stuff deliverable at their home. And the lab calls them for the sample collection from home. And that is provided to their at home. And then the reports go on WhatsApp and stuff like that. So this was a complete workflow which was implemented exactly in 7 to 8 days by the IT department. And then we could, use this particular video consult as one of the way to still reach out to the customers, especially for the OPD. So that was one of the very important opportunity which I could mention from my side. So even if the situation improves going forward, but I am still seeing this as one of the biggest vertical. In fact, this can be a P&L in itself. A video consult can be a separate P&L for our hospital going forward. So the opportunity here, and definitely going forward, we are improving those things. Now, by June 3rd week, I am launching an app in which video consult is part of the app. So through app itself, without switching over to Zoom or Microsoft Teams, the video consult will happen within the app itself, wherein I can raise a question, I can chat with doctors and all that. So this is going to come in next couple of weeks. So this is how the whole scenario is globally, India was specific, and what Manipal has done so far.
Sure. Thanks, Rameshwar. I think that there was very, very pertinent points as far as the COVID-19 situation is concerned. I'm sure the patients of Bangalore would be benefited by the app which you're launching shortly. They can reach out to doctors in Manipal and get themselves treated. That's wonderful. Thanks for the insights. So next, maybe once because we have seen what COVID is, how COVID has kind of changed the entire ecosystem as far as healthcare delivery in India is concerned. I think the previous two speakers have shared their thoughts and experiences. Now, because we're talking about teleconsultations, video consultations as a mainstream mode of healthcare delivery, I would request Prashant, who's a CIO for Max Healthcare, to share his thoughts on how does he see the role of telehealth change the landscape of healthcare delivery in India. Prashant?
Thanks, Dr. Naresh. See, I would like to start with the of course Nand Kishore has very well explained about the impact which COVID has actually given to the healthcare industry, and apart from healthcare industry, some other all across basically which it has given. So I'll start with a phrase that COVID has actually drawn a line in between and divided the entire healthcare landscape into pre and post. Now we can very well say that okay, so what happened pre-COVID and what is happening or what would happen in the post-COVID scenario. So as far as telehealth or telemedicine is concerned, so we have been talking about this particular topic for a long time. Now, what COVID has actually given us, it has actually increased the value proposition and realization as far as the usage and the perception of telemedicine is concerned. So, just to give you, pre-COVID scenario basically, and a lot of healthcare organizations were already using teleconsult, and so was Max also. Maybe few were dependent on the third-party aggregators like Doc Prime, Practo, and there are several other platforms as well, which were aggregating with the respective healthcare organizations. And a lot of organizations were already using teleconsults in the follow-ups specifically, the follow-up use case. That was the use case which was absolutely working well for several organizations. So in healthcare, in Max Healthcare also, actually we were also in one of our group hospital. Actually, we had a tie-up with government projects under the PPP model, and we were already doing more than 3,000 teleconsults per month. So which was basically from B to B to C, basically from business to customer, basically. So this was already happening, and now the realization has actually increased. Now, if you looked at the post-COVID scenario, now because of the fear of infection among the people, the usage of the teleconsult or similar platform has actually significantly increased, and the adoption we can see the increased adoption, and it is trending up day by day. And in this particular scenario, even the telemedicine guidelines actually, which has been published by Government of India, Ministry of Health, has actually augmented the fast development of these platforms. So much so, basically, when we started in the B2C segment, basically. So now, started with say 100 or 200 consults per day. Now we have reached near about more than 9,000 teleconsults per month, basically, which is part of, you can say, the 15-20% of the entire footfall as far as the OPD consults are concerned. So now, having said that, we have actually, and everybody is witnessing that the doctors are pretty much comfortable, and they have actually perceived the usage of the telemedicine platform along with the patient also. And because of the fear factor, patient is also quite comfortable. But still, what I feel as a gap is basically, if you typically understand the workflow of the entire teleconsult, basically, as what Nand Kishore also explained, basically, it starts from taking the appointment, then patient pays for the service, and there's a link which goes to the patient, and then patient uploads the diagnostic report and symptoms like that, so that the doctor can actually see what are the conditions and write the prescription, and which goes back to the patient. So this is the typical workflow actually, which is being followed as of now. Now there is a missing link actually, so where the doctor is actually unable to do the point in time vital checking. So that is what the piece which is actually missing, and wherein I can see the adoption of the wearable devices along with the IoT and sensor devices will come into the picture, and it will really augment the overall teleconsult scenario in specifically in India and across the globe also. So this was about the teleconsult specifically and the adoption and how it is increasing, and what can be done in the future actually in terms of attaching or the interfacing with the teleconsult existing platforms with the wearable devices and along with the IoT sensor devices and all. Now there is very interesting element which is coming up along with the teleconsult, which is coming up, the realization of the healthcare at home piece. So there's a separate segment, in Max Healthcare, which takes care of a lot of services, and the business lines, which takes care of a lot of healthcare, services which at home. So we've recently launched the home isolation. There are a lot of other healthcare players have also started launch the home care isolation packages, wherein there's a set of there's a sequence of event actually for say 7 days or 15 days, wherein the patient is patient receives kind of multiple kits to monitor the vitals. There's a set frequency on which the nurse or the TL or the doctor actually calls the patient, sees how is the health improving with the patient and all. And let me tell you, this is getting a lot of traction from the market. And I can see, by looking at other healthcare players also, and it is very well taken by people also across. Because looking at the fear to coming to the hospital, actually this is some scenario which is trending up, and I'm 100% sure it will double up actually whatever is the pace right now at which it is actually going on. So now looking at the marketplace of the telemedicine market basically. So it is in 2019 it was valued at $45 billion. So which is expected to grow at 19% CAGR from say 2020 to 26. But I still feel actually personally that the rate will actually more than what we are actually anticipating looking at the current scenario. Now coming to the regulations basically, so which is absolutely needed, in this particular current scenario. Now the regulations like DISHA, like Digital Information Security Healthcare Act, along with the Data Protection Bill, and a lot of health exchanges which the government is also working relentlessly these days basically, which actually give a new landscape to telehealth and telemedicine market in India basically, and that is very much required, so that the interoperability can be very well used in all these platforms, and actually we can really see the seamless interfacing between all the pieces which are part of the telehealth and telemedicine. Now the question comes to the market in the mind basically. So is it a temporary phase, or just because of the fear people are actually using the telemedicine or the teleconsult platform, or it is going to stay also? So we did a very interesting survey actually recently, maybe 2 days ago only. So wherein actually we have sent only pinpointed 2 questions to the patients who are actually availing the teleconsult services as of now, and we specifically asked 2 questions. One is, what was the overall experience of the teleconsult platform which you are using and talking to the doctor using that? And the other was very interesting question, that post COVID would you like to use these kind of technologies? So surprisingly, 70% of the people said yes. So which actually gives the heads up for all the technology players as well as for the healthcare, that this is not a temporary phase, and this is not just because of the COVID. What COVID has done is actually it has given the realization and the perception both for the patient and doctors basically, and it is going to stay. So this was the overall scenario which I just wanted to discuss and share. Thank you, Dr. Naresh.
Sure. Thanks, Prashant. It was wonderful. I'm sure everybody in India or people managing technology in hospitals and healthcare delivery centers would appreciate that before COVID struck us, telehealth, teleconsultations was just one of the initiative which a department would bring about, right? But I think post-COVID, it's come to a situation wherein every hospital, every healthcare delivery center needs to have separate vertical which does only teleconsultations and telemedicine. I'm sure this is going to take up quite a bit in the time to come. So now, because we have talked about telemedicine, what telemedicine can do, what it can, bring a change in the entire ecosystem, I would request Salim, who's the CIO of Omni Hospitals, to share his suggestions, recommendations, if any. Say, for example, if a hospital has not done teleconsultation till now, is planning to do start their teleconsultations, what recommendations can he give, or what experience do you want to share? Salim?
All right. Thank you very much. I think every gentleman has given very insight of this topic, what we are trying to cover and put our thoughts. So having said that, the telemedicine will be a platform whereby the going to enable to the first in place, that is the patient engagement, and which is very important for every hospital, every healthcare organizations to keep their patient engaged on continuous basis. And we have talked about that how and where it is going to add value, and the as it has been legalized by the government, and 75 to 80% of patient fraternity is saying that the remote consultation is acceptable, and which is going to help the hospital and the patient to ensure that no transportation is happening unnecessary, no need to take time to work, eliminate child or elder care issues, on-demand options, access to specialties easily, and less chance of catching new illness. And the getting the once there are a lot of people once they go to the hospital, they get a kind of anxiety. So they are in for some time they are in a different thought process that they are trying to be away from there. And then waiting time is going to improve a lot, and finally it is going to enable better health care. Overall, it will be helping to the patient to hospital to achieve the patient experience if the telehealth technologies are in place. But the question is that how it is going to help to the clinicians, the healthcare provider, this component is going to use to only the patient engagement, patient engagement with quality of care, and we have to just dig a bit inside and start talking to the to the product owner that how they're going to inbuild, rather than going and integrating and making interoperability of a third-party solution. But if those product-based company who are claiming they have a EMR, EHR, PHR, which is taking care of the complete longitudinal record of their patient under their group of hospital, beyond the group of hospital, whether it is the private sector, public sector, it should work in integrity of in maintaining the complete clinical data in one place, so that the doctor, the clinicians who is going to do a remote consultation, or it is going to be the treatment and as IP, so that the complete clinical data should be available, and the CDS is supposed to work on top of it to take the right decisions to treat the patient. So in that direction, telehealth, it was the people who are not definitely was not talking about, even the doctors were have some constraint, there were some legal issues, and the adoption was one of the big challenge. And the patient was one of my friend has covered. The patients were more keen to talk to the doctors in person to get more satisfactions in during their treatment episode. So now those things has been changed, and this clinical remote consultation, telehealth consultation is a kind of a component which should be a must-have feature into any applications, whether it's HIS, CIS, or EHR, PHR, what we are giving the name. It's a must-have feature. Without this, definitely the hospital would be thinking to go ahead for that product. So not only the hospital, there are the constraints from the hospital, and now the constraint from the hospital in terms of adoption that has been wiped out from the clinical fraternity. Now the product owner, the product healthcare product-based companies, they have to come forward to ensure that this is the integral part of their product roadmap, product line, and the product stack. And without this feature, definitely they will not be able to survive, or the hospital will not be able to achieve the real-time patient and provider experiences. So having said that, doctors are coming forward to adopt the technology, because I just a couple of days ago I met with Dr. N. Krishna Reddy, the head of the Access Health and the former founder of Care Hospital, he was saying that Salim, still my statement is the same. That rather than I as a doctor adopt the technology, let the technology adopt my needs. So he said it means that what he was saying that earlier there was a constraint. People talk about decades ago because there was a technical constraint, and of course it was not cost effective, but the technology has come way ahead, and and the adoption constraint from the clinical side day by day in India is becoming better and better. And now this COVID epidemic, which has been a push to the doctors to adopt the technology rather than avoid it, and they cannot avoid it because the doctors are asking that I need my entire patient episode integrated, whether he's taking the record on the teleconsult platform as a primary care patient or home care patient, but when the patient is going to come down to the hospital days and the needs, the doctor is going to call, and then he started the treating as the patient as IP. So all that encounter and episode which has been made during the remote consultation that's supposed to be available into the hospital, which is going to help to the doctors to take the decisions, and then help the patients to spend a pocket which was in terms of the lab and radiology test he has done externally, and those records are available for the doctors when he started the inpatient treatment for that particular patient. So that's the area that is a little bit challenging, which where we as an organization we should encourage our current vendors who are working with us. And there are some EMRs where I know the Max has got an EMR. We are getting an EMR, the Bion work, which has been implemented at the Vedanta group. So that those applications, the tele consultation is absolutely is not there. But running the solution, this kind of solution in silos, it is not going to add value in terms of delivering the quality healthcare. And the quality healthcare is going to, until unless we are not going to achieve this goal of from the organization perspective, there is the missing patient and provider experiences, which is backbone to in terms of improving our top line and line. And if we are not achieving, and this is the right time that we have to start thinking and debating and inviting the product-based organizations and asking them to look at, and rather than they put in trouble that the integrations with the third-party applications is good. We can do the integration. That technology is there, but if though I have worked in a product-based organization, I'll be looking forward to the entire solution in one umbrella rather than having a different component, which makes the hospital cost-effective in terms of maintainability, sustainability, and reliability. Which is again in terms reliability in terms of the data security, rather than I send my data from this database to that database to this database. Definitely it's going to happen, but this is the right time the product-based organizations to come forward to have a which enable the hospital, the healthcare providers to have a longitudinal record, which gives the real-time CD assess at point of care between the patient and the doctor. That's what the area that I wanted to just put in, because most of the area has been covered by all the friends. So that's all from my side. If you have any question, I can answer on that.
Sure. Thanks, Salim. I think we've brought out very important points from an implementation perspective. I think I can share my couple of experiences when we've started implementing the solution at KIMS and what I've heard from other hospitals. While the technology is kind of an agreed model of what would have telemedicine solution might have, right? More or less it is standardized. One or here and there features might differ. But I think one or two more important points, as Nandakji also said, is the behavioral aspect of people. Because none of the patients till now have kind of might not use a platform to consult a doctor. Till now, they've always thought of, you go to a hospital, pay consultation fees, sit in front of a doctor, talk to him or her, to take the feedback and then come out and get themselves treated. But this kind of new channel of medium of consultation or healthcare delivery, which we've seen. But from a provider standpoint, what I have seen is there are a lot of concerns before doctors hooked onto any of the platforms. One of the concern which many of them have raised is, where is this data getting stored? It's an online consultation. It is not from the hospital's network. If you subscribe to a third-party solution, so it might not be a solution. So people were, where is this data getting stored? That was one of the major concerns which people had. Second, how do we train doctors on using the solution, right? The majority of the doctors have not been trained on using a telemedicine solution till now, because of which they had concerns of how to use a technology. So that was two things. Third thing is one of the major areas which patients also have raised concerns is, who's going to foot the bill? Right? Will the patient foot the bill for using this kind of a platform? Can the insurance companies, reimburse such consultations? Such kind of questions or concerns is what people have raised. I'm sure in the time to come, if telemedicine is going to survive in India and become a part of the mainstream delivery of healthcare, I think insurance companies also should be up to speed of reimbursing such consultations also. So, couple of things which I've wanted to share and also request the panelists. Anybody can pick up this question and share the suggestions. One of the things was like, do you have any other technologies which you've kind of used or using currently, or which might help treating patients in such kind of problems, right? It's open to any of the panelists can pick up. Do you see any such new exciting technologies which can help delivery of healthcare? Anybody wants to pick it up?
Shall I answer on that?
Yeah, Salim, please go ahead.
Yeah. See, as you said, that the adoption of the technology from the clinical fraternity, the clinicians, especially those who are treating the patient, they have three major issues. They have three major issues. The first one is the performance. The second one is the performance. It should be faster than paper. If they are going to do prescriptions in a minute, the system should at least provide that feasibility to script that in a digital form and in a minute. They are not saying that a half minute. And the third thing is that the solution is supposed to be made in such a way that I don't need any training. Because I am a doctor, I do understand all the clinical jargons and all the parameters. So I don't need any training. So if the solution which has been made, which have three goals, and these goals which I have just after talking to too many doctors, and including Dr. N.K. Krishna Reddy and the former founder of CARE and Dr. What we say that Dr. Nageshwara, the known pediatric cardiology doctor. So they, after talking to a couple of doctors who has got a lot of constraint in terms of adopting the technology, they said that after discussing, I found that the solution has to it should be faster than paper. It means it should give the sub-second response. That technology we have to, and that kind of technology we have to adopt, which gives them faster than paper in sub-second response. And the third one is that it has been made in such a way with the current technology available that it doesn't need any training. Has been proven. He's one of the doctors said it is. If I'm saying that it is proven that if I'm going to buy a smartphone or Android or iOS, so I need any training to operate that? So this is the very layman kind of example they give, and they say that on top of it, it should be the template. I have a limited knowledge. I have a limited memories in terms of the calculation, in terms of the the patient condition, in terms of the drugs. So if he gave an example, I'm talking about again Dr. Doval, who is the renowned oncologist in that Rajiv Gandhi Cancer Hospital. He said that do have a chemo manager. And chemo manager, if I'm saying that the patient has got a lung cancer and this is the size of the size, and it is the XYZ size, and the stage is that the chemo manager should say that it should go post chemo or a pre-chemo of the surgery, and what drugs and what would be the dosage, and in that I should have a means I cannot make a complete changes. I can make a changes in terms of that 10 to 20, 30%. I can put my permutations combination and move ahead. And again, it should go to the board, cancer board, that this is what I have made the changes based on the guideline that I have made the changes, and he has to go, and the board, cancer board, tumor board should ask the question. He has to justify that this is the reason he has done that. So that kind of applications the people and the healthcare, the doctors are talking about, and I don't see any are available in India right now. About EMR, because a couple of hospital has been implemented that EMR, that Max Hospital Vista EMR has been implemented, which has got a template engine. And the one that Vedanta I'm looking at, that they have implemented that work by the Bio, which was again the legacy of iSoft. Because iSoft has tremendous workflows, but it got really failed due to one reason, because it has got the performance issues. The data as from the patient that treating the doctor treating the patient, that it was taking too much of time to retrieve the data from the spine and send the back data into the spine. So this is what I would say that the technology is supposed to be available, and top of it, the technology should not be costly. The hospital they are not ready to pay a single penny for the licensing and all. And those, I think those from the beginning, but now based on that, the lot of open source technology and reliable technologies are available. And in terms of, if we'll talk about the database, I would suggest the GTM MUMS is the database which gives this only the database which gives the subsequent response. And the example of that, if you'll see that one example of Citibank in India, I've never seen that Citibank ATM is. I'll give you a very simple example, because money is not that's a different story. But I've never ever noticed, and I'm talking about 2008 until now, that the CTA maybe that I have not seen it. It could have been down, but due to the technology, it has been down. I have not noticed. But other ATMs, they are RDBMS concept they are using, and I found every now and then that's it is down, and I don't know and then I find out what was the reason, and I spoke few people, known few people there in the banks and the technical team, and they say that there is limitations and in the database which related to the performance, and that we have that's the reason it goes discontinued for some time. So this is what I would like to add. If I hope I have tried to answer the question in little detail.
Sure.
Dr. Naresh, can I just jump in here for a minute?
Yeah, please go ahead.
Yeah, so let me just bring you guys back to the agenda. What we had today was redefining the healthcare, scenario post-COVID situation. So if you look back and go back to that particular topic, so I have a couple of thoughts around this. Now, where is the opportunity? Again, I go back to my same point that yes, this pandemic is going to be there for at least next few months or a year. We don't know. So how do we leverage this situation? That's my main point. I have two thoughts on this. Now, how this is going to play a larger game is that this will definitely boost your Make in India initiative. So you're going to make more ventilators. You're going to invest more into the manufacturing facilities for various drugs, the sanitizers, etc. So that is one clear opportunity from the supply side, if I may see that clearly. The second is that definitely we need to have more and more footfalls, and we need to have more and more contactless or remote kind of models wherein patients are comfortable enough to contact us, because there will be a phobia still. Patients will not come to hospital as freely as they used to come pre-pandemic situation. So therefore the telemedicine or teleconsultation or whatever those tele models we have, we'll have to further enhance those models and make those models workable in a more and more efficient way. So that is the second most important, perspective which I can see. Along with that, when you kind of attend an OPD patient, you need to also take a couple of vitals, maybe a blood pressure, body temperature, and all that. So some gadgets which a patient can handle sitting at home, the easy to use gadgets and reliable gadgets. Okay, so if they can be manufactured locally and they can made affordable to our customers, so probably then when the doctor does the consultation, he has a holistic view of the whole case there. So telemedicine and the gadgets, the mobile and the health gadgets, I think that is one area where I will see a lot of those investments coming in. So that will help us to get more footfalls through e-consultation way and get maybe an additional revenue. The next thing is that this has already brought in some kind of, or to a very larger extent, behavioral changes from the clinician side as well as from the consumer side. So earlier they were not very good for video kind of consultation, but now yes, they see that there is a big benefit in doing that. I mean, myself, I had a couple of such consultations on video, and it worked quite well for me, end to end. That's the next thing. Also, the mobile app, what we guys normally launch for our customers, those apps will need to have a lot of basic features like, let's say, symptom checker. Okay, can you not allow the patient to do the basic symptom checking on the app itself? And can this app integrate with government's Arogya Setu app? And see that the whole environment, the ecosystem can work in a more coordinated way. So I think these are a couple of potential areas which I believe, because that is the topic of today's discussion. So I think these are going to catch momentum very soon.
Sure. Thanks, Mr. Nandkishore, for that.
So, Dr. Naresh, just to add what Nandkishore just said and explained, basically, there are two more areas basically where voice bots and chat bots actually that will come into the picture in a big way. Actually, we are doing some piloting also actually around that, wherein because we have already created a helpline wherein we are getting a lot of calls actually, which I think it would not be possible for a human to attend those calls. So what we are doing is, and going further also, the use of voice bot and chat bots actually. So we are integrating with the PRI lines so that one set of filtering can be done from these bots itself, and then we get the clear-cut filtered calls so that the load on the call center can be reduced. So we are already using such technology. And just quickly to what Abdullah mentioned in terms of the difficulty which a lot of people are getting in the adoption of the EMR basically. Mr. Abdullah, actually, there are 10 reasons actually why EMR fails. I think there are 20 reasons why it should be adopted. Actually, it is a topic actually we have been discussing for many years. As far as the adoption challenge of EMR is concerned. And let me tell you, A technology or B technology, technology is never a constraint. Basically, it is just a mindset which we have to change. We have to actually tell them that this is the final outcome which is going to people will be receiving actually after in terms of clinical trials and a lot of research topics which we at Max are already doing it. So like what you were talking about GTM mumps, we are using GTM mumps actually in the EMR itself, and it is, let me tell you, it is not a very user friendly system, but still the adoption is very high because so it is being governed by a governance structure actually which we at Max Healthcare is having. So all I just wanted to say is it is the governance issue, not the technology issue. A lot of technology are still available actually, can actually ease out the transaction. If you take an example of speech to text and handwritten recognition tools actually, which we are already using one of the group hospital where we have not changed the way a doctor writes the prescription. Whereas from handwriting skills, we are just transforming whatever doctor is writing, and respectively we are getting the medicine, investigation, everything. These are technology which we can maybe talk offline, and I think it is really helping the doctors the way actually they are transforming the electronic records and all.
Let me add you. Let me give me 1 second. Let me add you, Prashant. Maybe that we have joined here the Max recently. I have worked for Max more than 5-6 years to deploy that product. Okay, so that's one thing. I know entire inside. Okay. And as far as concerned that it's not user friendly, that's what I'm saying. That's the technology, the kind of technology is available. I'm talking about AI. I'm talking about machine learning. I'm talking about to collate those things and made a solution which have 3 goals. It should be faster than paper. It should be sub-second response, and it does not need any training to the clinicians. If that kind of we have, and we can make it, the technology is available, we can make it. The constraint from the clinical fraternity, the constraint adopt that, okay? They will adopt it. No matter, in Max, OPD is not live till yet. And we got live in 2009, right? And I was the one of the player to leading that one of the component I was leading and during that implementation, and then Dr. Pravez. Okay. So I'm not saying that it is a problem. It is a problem from the constraint from the clinicians, which we can omit by giving the solution, and those solutions should be made based on 3 goals. And if a solution which has been made without any goals, I don't know how beautiful they made it, but if these 3 things are missing, it will be a miserable for the organizations to ask the just to adopt it.
Sure. That's implementing technology in a hospital is a never-ending topic, and we be at the forefront of all that. So everybody has their own kind of experiences to share, right? We are almost running out of time. I think I thank all the panelists, Mr. Prashant, Mr. Salim, and Mr. Nandakishore from Bangalore. Thank you very much.
Thank you.
And
thanks a lot.
Thank you very much. Thank you. Thank you.
Thank you very much.
Take care. Take care.
Thank you. Bye-bye.
Yeah.
भारत एक युवा देश है। विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बात के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये मेरा साथ मैं हमेशा कहता है, IT plus IT is equal to IT. Information technology plus Indian talent is equal to India tomorrow.
Ready. I'm. It's a Facebook. Facebook पे था
भारत एक युवा देश है। विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बात के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये बड़ा साफ मैं हमेशा कहता आया हूँ, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया ग्रोथ। भारत एक युवा देश है। विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बात के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये मेरा साफ मैं हमेशा कहता आया हूँ, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया ग्रोथ। भारत एक युवा देश है। विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बात के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये मेरा साथ मैं हमेशा कहता है, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया टुमारो। भारत एक युवा देश है। विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बात के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये मेरा साफ मैं हमेशा कहता आया हूँ, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया डेवलपमेंट।
Yeah. Welcome everyone.
Hello.
Namaskar. Namaskar, Dilip ji.
Namaskar.
Hello, Ekta. How are you?
I'm good, sir. How are you?
I'm good. Welcome, Sanjeev ji. Thanks for joining. So we are starting the session here, and a few of the speakers are still joining. They are facing some technical issues, but I think in the interest of time, we'll start and let them join in when they are able to. So this session is the topic is that how COVID-19 is igniting a redesign of the healthcare ecosystem, and we have with us in the panel, we have Sanjeev Kanoria. He is the founder of Suvash Multi-Speciality Hospital, Navi Mumbai. Welcome, Sanjeev ji. Thanks for joining. We have Ekta Modi. She is the COO of Parul Sevashram Hospital, Vadodara. Welcome, Ekta. Thanks for joining us.
Thank you, sir. Thank you.
And we have Dilip Patil. He is the co-founder and director of Trivector Group and Baby Quest Cryobank. Thanks for joining, Dilip ji.
Thank you.
Namaskar. Yeah. So we are all seeing the huge impact of COVID in the healthcare ecosystem. The numbers are still rising everywhere, and it is creating a lot of strain on the hospitals. The hospitals are overloaded. Their doctors are overworked, and the whole government machinery is right now involved in this situation of managing COVID, and this is impacting the whole healthcare ecosystem in several ways. So I will request each of the panelists to start with your initial comments that how this has impacted both from human resource perspective, financial perspective, management perspective, regulatory perspective. So I will request each of the speakers to first of all give initial comments, and then we will do a second round of the panel discussion. So I will request if we can start with Ekta Modi to start with. Ekta.
Okay. Pleasure to be here and among these dignitaries, and everywhere it's COVID, COVID. You don't hear any other word other than COVID. Either it is COVID or either it is Corona. So I'll just share a simple thing what happened, that even if someone calls us for the vacancy of the ICU beds, back of our mind is only COVID. So then patient has to say, Madam, हम non-COVID की बात कर रहे हैं. So such is the era and the mindset of people working here in hospitals. And as you rightly mentioned about the manpower, and see, government has, like, talking about our hospital, we have to dedicate 175 beds for COVID. And initially, it was very tough for us because to manage the beds, the inventory, doctors, nurses, staff. I mean, it was very difficult for us to at least convince people to start working in COVID areas because of the society is not very clear about what corona is. So most of the employees are facing discrimination. That is what I hear each and every day when I come in morning. मैडम हम कल से नहीं आएंगे, हम ड्यूटी पे आते हैं तो लोग हमें मना कर देते हैं, and all such stuffs. And thinking about like sharing about the revenue and this thing, at present, I think everyone in healthcare will agree to me that we don't see the cost of the safety equipments or the safety PPE required for our staff because they are going to perform the duty only and only if management is providing them with the needed safety equipments. And it is a paradigm shift. We have shifted our thinking. The procurement process has changed, the purchase process has changed, the training has changed. Every day it's a virtual, video call training to our staff who are working in COVID. So like that is the situation at present in Vadodara and Gujarat at present.
Yes, and I think this situation is in other cities also. So may I request our next speaker, Mr. Sanjeev Kanoria, to please talk about the impact of COVID on the ecosystem, healthcare ecosystem, which you are experiencing. Sanjeev ji. Sanjeev ji, please unmute the phone. Unmute your phone, please.
Okay, sorry. I have a different perspective on COVID. I'm a doctor. I'm a liver transplant surgeon based out of UK. And I have seen how COVID policies in the UK have unfolded. I am very close to the government here, so I see exactly what is happening. I think we have to be sensible about things. I think there has been an extreme overreaction and exaggeration of COVID. That is my personal views. And if you look at the data properly, and if you look at the data and you relate it to population statistics, right? And if you also look at the difficulty in implementing infection control in the community, particularly in an overcrowded community and overcrowded situation in India, we will suddenly realize that we are totally off balance. So in a population of 1.2 billion, right? Even if we say the reported infection rate is 300,000, let's double it. Let's make it 600,000. Let us even make it 1 million. Let's say that the infection rates have been unreported in India, and it is 1 million. So if you take 1 million as the infection rate in India, okay, that is still 0.04% of the population of India, 0.04%, right? Now let us see how many people have died. The government has reported, I mean, as of today, according to WHO from India, the data is 8,000 people have died. Okay, 8,000 people is 0.0007% of our population of 1.2 billion. Let us double this death rate. Let us say that the government is unreporting the death rates. Let us make it 20,000. Okay. Even then, the percentage is 0.0007%. Every day in India, according to WHO's data, 6,000 people in the normal situation is dying due to poverty, due to starvation, out of which 3,000 are children. Every day this is happening. Today, suddenly, in a situation of India, we have reduced our GDP by 40 billion per month, right? Can you imagine the impact on poverty and starvation which will occur in the economy? That is one thing. So I feel that there's a huge overreaction. People have got very scared of COVID. It is impossible to implement community infection control. It's impossible. Even in hospitals, we struggle to implement proper infection controls in most hospitals, in spite of having sanitizers, in spite of hand washing, in spite of gown scrubbing. Hospital-acquired infection is a real thing. So my suggestion and my thinking is that we need to come to a balance. And most of the countries are now coming to a balance. They are now weighing the economic cost of damage to what is really happening and what is the real death rates in the community and who are the people who are dying. And these are the things that we need to bear in mind. So what we are seeing, as for example, if you take our hospital, it's a brand new hospital with a lot of cost it has been built in Navi Mumbai. So we have spent close to $100 million in building a world-class facility in Navi Mumbai, a 400-bed multi-speciality hospital. It has been fully designed by me from the UK. And we have seen that the PMC, the Panvel Municipal Council, took over the hospital for 3 months. We had one COVID patient who was admitted and that was discharged. Just one. And they took over the whole hospital.
Okay.
So I'm just saying there's a total madness about COVID. We need to come back to reality. This is my view.
Excellent inputs. You have given a perspective about the percentage of the patients and which is very low. Dilip ji, you are in this sector for decades, and your perspective on the situation. Dilip Patil.
Yeah, in fact, I can't agree enough with Dr. Sanjeev Kanaria. Are we really overhyping this pandemic? Because we are forgetting the underlying issues of the existing patients, like TB patients. Almost 4,000 people die every day in India due to TB. So we are just neglecting these patients or other overlooking the underlying problems. And then, as Dr. Kanoria rightly said, hospital-acquired infection is something which has been there forever, which is there still, which is more prominent now in the days of COVID, and which is going to be there. So we have to really concentrate on controlling this hospital-acquired infection. And then, as I told the audience during my last webinar, that hand hygiene and surface cleaning, we are harping on that. We are harping on social distancing. That is important. Those are the gold standard. But then, is that enough? We have to do much more. And then we are forgetting that air is something which we are overlooking. We are just concentrating more on hand hygiene and surface cleaning. But what about the air? Because whatever is in the air settles down on the surfaces and then creates the contact point. So that is exactly what I'm trying to propagate, that air cleaning, air purification or air disinfection, that is there to stay, that is there. So we have to augment our existing infection control practices to have the sustainable solution, because COVID is there, COVID may not be there, but then hospital-acquired infection and airborne infection will be there. So I think we have to concentrate on that.
Sure. So we have heard about the situation. Ekta talked about how much there is a fear in the society about this situation, and even your staff are facing discrimination. Sanjeev highlighted about our overreaction. Dilip ji talked about the air infections also. So let me ask you that the whole because of the various situations of the lockdown and the whole fear in the ecosystem, there is a supply chain management issue, there is a human resource management issue, there is a financial loss issue of the hospitals. And we were like in the panel in the morning, there were some hospitals who mentioned that this financial strain will keep on going on for at least 4 or 5 months at least, because there is still the disease will stay in the system and people are still scared of going to the hospital. So the question is that how fast you will see the recovery of the healthcare ecosystem, the hospital business, hospital revenue coming to the normal levels.
I think, sir, it would be a very difficult guess to make when the things would settle. But I think it has caused us a very challenging reform. Hospitals, talking towards the positive side also, hospital now have the era to reform themselves, to reform their practices, to reform their entire operations. And I think, as we say that COVID has got us the digitalization of health. So I think everything is going to be EEE. The hospitals would we have to be empowered, we have to be engaged, we have to be equipped, and we have to be enabled for each and every processes. And COVID has made us sure that it is what is acting is people marketing. Now, our marketing guys don't market ourselves, but it is people who are marketing ourselves. And COVID will actually focus as in how an hospital is functioning in chaos situation, in supply chain problems and inventory problems. And I think we have reassuring prospects which have provided us opportunities for healthcare sector to make reforms. Like there are boundless sphere of information, effortless communication, and endless opportunities by literally finger click. That is what I can say. And the restructured dynamics and like now patients are playing a very vigorous role in safeguarding their own health. And I have like the technology has taken over. I was just talking to one of the person in our college that there are apps coming up which will be helpful in screening. They'll probably give us the screening score. So before the patient is in OPD, we'll have the screening score and we can divert the patient and required OPD.
Great, Ekta. Thanks. Sanjeev ji, what's your opinion on this impact, the financial impact? There is a impact on the human resources. Nurses are impacted, doctors are impacted. So, what are you seeing in the ecosystem? And also, you can give a perspective for both from UK and India. Sanjeev ji.
You see, I think sorry, I'm not.
Yeah.
I think a lot of the fear is going away. Both in the UK, people are understanding that the infection rate, the people talk about R0 rates and R1 rates, etc., without really understanding the full implications of it. People are seeing that the death is only in the higher age groups where there are issues with medical issues as well. So particularly when people have severe cardiovascular problems or diabetes, those are the people with old age who are not able to mount or be able to, who are succumbing to this disease, you see. And we have seen that in the United Kingdom. So if you look at the United Kingdom data, for example, almost 40,000 people have died. And we run one of the largest chains of dementia care facilities in the United Kingdom. So we have about 3,500 beds, which looks after old people with dementia. And what we have seen is that out of this 40,000 people, 15,000 deaths have occurred in the dementia care homes. See, because where people are immunocompromised, where people have cardiovascular diseases, they are of an older age group, and they have medical illnesses like diabetes, etc. The other 25,000 deaths have also mainly occurred in the population, in the older population with similar sort of risk factors. See, in the younger population, the deaths have occurred, but they are the total number of deaths in the younger population, according to the UK data, is approximately around 3,000. Of the total 40,000 deaths that has happened in the United Kingdom. Yeah. So these are some of the data that we need to focus on and understand in trying to manage this disease. Number one. Number two, healthcare technology has now taken roots because of COVID. People are understanding the importance of healthcare technology, and healthcare technology will get a big leap as a result of COVID. There will be many changes that will happen, which will improve the processes in healthcare, because whenever technology comes into healthcare, there will be process efficiencies. As Ekta was mentioning, that tools for apps for screening patients based upon risk factors would help us in trying to see which patients need to be admitted to a hospital and which patients can be managed at home. Right? And those things would be very useful. So there will be certain efficiencies that will come into the healthcare system. But my caution is that we need to be careful about not blowing things out of proportion, particularly in countries like India, where we have to, weigh things against economic realities. We have to weigh things against other infectious diseases, which are a major problem, as was being pointed out. the tuberculosis is a major infectious disease. That's a big problem in India, and we know that active tuberculosis is very, very infectious. So there are certain other things that we need to bear in a country, in a developing economy, which is different from a developed economy.
So, excellent point about this difference between developed economy and developing economy, and our types of diseases are different, types of challenges are different. Dilipji, your perspective about the situation, and how do we how are you seeing the next 6 to 9 months?
Actually, COVID has given us opportunity to embrace the technology, to think out of the box. Means the traditional thinking of infection control. Means along with traditional thinking, we need to think beyond traditional thinking, and then COVID will be there for a few months or maybe a year, and then we have seen such. COVID is of course a serious pandemic, but then as I said earlier, and Dr. Kanoria also seconded that the most infectious diseases or the most killing diseases, we should not be overlooking that, and we should be in a crowded country like India, where social distancing or use of hand hygiene or surface cleaning, it may not be adhered to in toto actually. That is impractical. So we have to find some solutions, some other solutions. We have to adapt some new solutions. We have to use new tools for controlling this infection spread. And fortunately, means this pandemic has opened up the opportunities for the companies and the innovations in controlling airborne infections or surface infections or whatever. So we are part of that solution providing this, team actually. So we are really helping hospitals protect the patients, not just the patients, but the healthcare workers from mitigating the risk of spread of infectious diseases.
Sure. And what is the like in these challenging times, uh, looking at any opportunities for changes in the healthcare, any are there any silver linings in this all challenging times in the dark clouds? So any opportunities you are seeing, Ekta, if you have any inputs on this. Ekta, you have to unmute yourself, please.
I'm so sorry. Talking about the opportunities, yes, every storm comes with a blessing also. So I think this has also taught us, as I mentioned, about reform of healthcare and healthcare technology. But I think as we say that old ways don't open new doors. So old keys don't open new doors. And so like this challenge is new. So the thinking level, the solution level should also be new. So what we have started in our hospital is because we generally are equipped and thought and made in management practice that we have to give our staff कि आपको ये करना है. But now going beyond that, the user level is very important. So we have now given flexibility and the changes and the facility to our user levels so that they can tell us what change they need to perform better in COVID situation, and which will also help strengthen the processes for catering the non-COVID solutions too. So as for a very simple example, we developed and have also got registered for a trademark for that, which we developed at our hospital. We developed a barrier. Usually we have this hospital curtains as a barriers between patients. So what we did is we developed an aluminium section and transparent curtain barrier which has to be kept in a patient's bed, and it covers from all the three sides. It has an opening from which the nurses can put their hand and just alter the medicines or give medicines or a pint or anything. Sorry. And so it has been serving very good because it is serving as a barrier, and as so rightly mentioned, the air. So how to curtail the air infection? So I think this type of barrier curtails the air infection also. So yes, positively, many new things are coming up, and even our staff are suggesting that we should do this, we should do that, and that is how I think we are involving everybody. And involving and empowering is the only way to go forward.
Sure. Thanks, Ekta. Sanjeev, how do you see any silver linings in these challenging times?
See, whenever a chaos happens, some order comes out of chaos. We all know that. You see, World War II created major reforms in the whole world, and the United Nations, etc., was created. So, out of this also, I think a lot of things will come out. The importance of technology will be realized in healthcare, number one. Number two, my feeling is that people will be there will be better hygiene control and infection control measures which the communities will practice, right? Whatever is practically possible in the Indian communities. So there will be greater awareness about hygiene and infection control, which will have, I'm sure, it will reduce many of the infectious diseases that we have in India, which is as a result of poor hygiene. So I think there will be some benefit from from raising awareness about COVID for the whole country. These are my views. And in terms of cost management, you see many hospitals in India, if you see the operating profits in many hospitals and the cash flows in many hospitals are limited because of the high cost of finance. So this will also give a realization to the government that maybe there should be a preferential cost of finance to hospitals, because hospitals is an essential infrastructure, and it will raise awareness within them that this infrastructure is really needed to be developed and to be promoted, and the government cannot do it alone, because we have seen this awareness that has come up. There is a huge shortage of hospital beds in the whole country. No one is putting up hospitals due to the huge infrastructure cost, due to the huge land cost, due to the huge finance cost of putting up a hospital.
Sure. So you have mentioned about that incentives being given by the government is an important agenda which has to be looked into by the policymakers. Dilipji, how do you see that?
In fact, the silver lining for me is that we have been propagating the awareness about airborne infections for the last few years, but then nobody was taking it so seriously. But then this pandemic has really spread a huge awareness about airborne infection. That's why everybody is wearing the mask. So that is the first step. So people have acknowledged there's a increased awareness about airborne infections, and I think that will go a long way in our hygiene, personal hygiene and social hygiene as well. So I have a small video to be shown. Of course, I'm talking about the new innovation, the technology of airborne infection control, which can be used safely around the patients 24/7 without much cost actually. So if you permit me, I have a couple of minutes small video animation which will show how the airborne infection is spread. So I will share the screen.
Yeah.
Yeah,
Let it be brief. Yes.
Yeah, it's 2 minutes video.
Sure.
Can you see this?
No, we can't.
Are you able to see it?
No. It's not appearing on the screen.
I think you're not able to see it still.
No.
Okay, maybe I will do it later on. So maybe
Okay.
you can, you can take the next.
Yeah, sure. May I return to our panel? Like Ekta, I can't see her right now, but Sanjeev, I want to ask you that what are the besides this tax benefits which you have asked about, which you mentioned about, like how do you are seeing the comparison between the healthcare system, how it is able to handle the situation in UK and how it is in India. Like, what are the major differences which you are seeing, Sanjeev?
See, all the governments went for a lockdown, and I think in the UK it is easier to get a lockdown because we do not live in overcrowded situations. You see, it is much easier to implement a lockdown, right? So the lockdown helped in reducing the spread of the infection.
Sure.
And so it was useful in the United Kingdom, right? And now the government is lifting the lockdown because the rate of infection has reduced, right? But everyone is forecasting that there will be another peak of infection, right? Maybe the peak will be lower, right? Maybe herd immunity will develop. Okay? It is already known that it is impossible to test everyone because COVID testing, the false negatives are so high, and unless you catch the infection in the replication phase or in the right window, you will get a miss. So you have to test a person almost every week to really get a sensible result from COVID testing if they are asymptomatic. Symptomatic patients are different. So if patients have symptoms, they must get a COVID testing. So I'm trying to separate the asymptomatic and symptomatic patients. Many people have got infection in the community already. And it is impossible to monitor, manage, and trace them. All the contact trace apps, etc., which they have tried to implement in the United Kingdom, have not really given the results that they were looking for. So it's all in trial phase. But at the same time, while all these things are happening, the infection is marching on. You know, so over a period of time, people will develop herd immunity. We do need to protect the vulnerable. You see, we do need to improve standards of hygiene. In a country like India, we have to be very practical and sensible. It is impossible to implement infection control in a country like India. What are the things that you will spray? People started to spray vegetables. Then people will start to spray their curries. Then people will they will die of insecticide poisoning. Just spraying vegetables with disinfectants is not going to kill the COVID. Because then you have to infect the boxes in which the vegetables are there. You have to infect the whole surrounding. It is impossible. So I think the craziness of the situation when you watch in a country like India, it actually is both heartbreaking and amusing. You see, and some high quality people, scientists, government advisors, need to create the right balance in it. This is what my view is.
Sure.
We have other pressing issues like pollution is a big issue. Pollution is causing disease in the young. You see, we have the young people suffering from chronic bronchitis with emphysema, pollution related to the disease. There's heart disease which is related to pollution. You see, air pollution, environmental pollution. These are the things that we should be focusing. We should be focusing upon improving the nutritional status of the poor people. Those are the things that India should be focusing upon, and not clamping on the whole country because 10,000 people, let's say 20,000 people in the whole country of 1.2 billion have died.
Yes. So what you are saying, Sanjeev, is that we have other diseases, other health challenges, and we should also address them besides COVID. Ekta, if you can talk about the situation of the non-COVID patients in this situation, we are listening from papers and TV that non-COVID patients are not able to access hospitals in a easy way. Ekta, if you can talk.
I think non-COVID patients are also in fear that if they visit hospital, they'll catch unnecessary COVID. So they don't want to take this that if they come non-COVID and they go COVID. So yes, a lot of non-COVID patients are facing problems to visit hospital for which teleconsultations or telemedicine is in. But for some things wherein they need to visit the hospital, so hospitals now have started creating special entry exit gates for COVID and non-COVID, wherein bifurcating them so that the infection rate is minimized. And a lot of IEC materials because it's only training, and educating that will help. So if we have proper education to them that okay, non-COVID area is different, COVID area is different, you will be taken care of. A lot of hospital practices are in place. So what we have done is we have deployed special social workers for non-COVID patients. And you won't believe, sir, like a lot of non-COVID patients, we actually have to counsel them. So we've actually set up a counseling area before they enter any OPD, so that they are clear that they are in the non-COVID zone, and it's very rarest thing that they'll be catching COVID infections. And for all COVID patients, proper precautionary measures are being taken care of, because it's like a tsunami. This COVID is like a tsunami. We don't know how the waves would be, how it will go. No one is able to predict it. It's a very funny virus. Thank you.
Thanks for putting that word funny there. Dilip, what do you consider this virus as? Is funny or not funny?
It is funny actually, and it is I would say it is the big brother of the earlier viruses like SARS or MERS, but it is overhyped or more pampered, you can say, because it is behaving viciously. But I will carry forward the point which Dr. Sanjeev mentioned about pollution, because pollution is also, I mean, somehow WHO and all these governing bodies, they are not really realizing that COVID could be airborne. COVID is airborne actually. There are mounting evidences which are suggesting that COVID virus or SARS-CoV-2, this virus can stay there in the air currents, or can be floating there in in the form of aerosols or nuclear droplets. So that is something. Just to put the statistics, this is the EPA statistics that pollution kills about 7 million people every year in the world. 7 million. So that is the single most killing this thing. And then indoor pollution is a major cause of this deaths actually. So all of us average, we spend 90% of our time indoors. And then we consume about 11,000 to 15,000 liters of air every single day. Compare this with the food or the water we intake. So the average human being takes about 3 liters of water, compared it with 15,000 liters of air. Then what we eat is about 2 to 2.5 kg or 5 liters of food every year. Compare this with 15 kg. So air is very important. And then unfortunately, the indoor air, we in the COVID times we say stay indoors, stay indoors. But the indoor air itself is 5 to 10 times more polluted than the outdoor air. And that is the EPA fact. That is the unfortunate fact, and that is because of all the chemical agents we use for disinfecting our houses, our washing machines, our utensils, floors, and all these things. So, and then also the material, plastic material, the TVs, the plastic cabinets, degassing, and all these things. So this is indoor air has to be taken care of. And then in a tropical country like India, we are more depending on the air conditioners. Means those are mostly windows or split air conditioners. So there is no fresh air coming in. We are recycling the air. So there is also studies suggesting that recycling of the air may be very conducive for growth of COVID actually in that atmosphere. So I think indoor air has to be taken care of. And then again, I will come to air sterilization and air purification, no matter whether it's indoor air or outdoor air.
Sure. Dilip, thanks for highlighting about the air pollution point. And Sanjeev ji, I want to ask you that in 1 year time, how would have healthcare ecosystem changed, like in terms of its overall operation and management because of the COVID situation? How do you see the impact? And if you can also give me a scenario about UK and India, that right now doctors are wearing so much PPE kits around them, so much safety and security standards are being maintained. Will all this stay after 6 months or 9 months when all this is over? Sanjeev?
No, I think there will be sensible infection control. Like as I mentioned, COVID has raised awareness about hygiene and cleanliness throughout the world. You see, so that is one thing which is very important. Number two, the situation cannot continue forever, right? So I think within a year's time, once people have seen a second wave come and go, maybe, and herd immunity and immunity in the population has become more prevalent, right? And people understand the pathophysiology of the disease, people understand who are the risk groups much more clearly, right? Then sensible measures will come. So I do not think that this PPE, etc., will continue for a very, very long time. Yeah, for the next 6 months, yes, of course, it will continue because it will take time. Wearing masks, wearing caps, wearing gloves, etc., for medical personnel is very, very important in any case, and they have been doing it for years. Whenever they're dealing with infectious people, we do that. So whenever we are looking at patients in the ITU, we have to follow proper measures when we interact with patients in the ICU. So doctors are already used to doing this. To train extreme measures in the community is going to be very, very difficult, in my view. See, there will always be loopholes and gaps. And again, I come back to the practical point that we have to be sensible and realistic about how we manage this infection in the community. And that balance we need to strike. You see, because people wearing cloth masks are not very, everyone knows that. You're just tying a hanky around your nose, etc. Because you can still, it depends upon the porosity of the material that you are wearing, right? So there's a lot of things, and people, even with gloves, they are touching their faces, etc. Right? But just because they're wearing gloves, they feel that they're protected because they wear that one glove in the morning and they don't change it. In a hospital setting, we are changing gloves very often. So every time we see a patient, we are changing the glove. But that is not happening in the community. Just by wearing the glove in the morning, they feel that they're protecting themselves and others, but that is not the case. See, so I think the practical realities have to come in. Practical common sense, as I call it.
Sure. And I think we are getting at the back on the screen. While it coming, I will ask our Diliti, last question in the panel, that how do you see that after 1 year, all these protocols of hygiene, safety, or PPE, will all these stay here, or we will get back to our old ways in the hospitals?
I think human beings, and especially Indians, we tend to forget the things when situation is normal. So I fear that this care which has been taken for mask and social distancing, this will be followed till the scare is there, and once the herd immunity is developed or the vaccine is available, people we are seeing that when the government open up unlock 1.0 and people from the marine drive without maintaining social distance. So that is, I'm sure this is very difficult for Indian psyche or Indian public to really follow. So after one year down the line, as Dr. Sanjeev Kanoria said, and also this, except for medical fraternity, who anyway are taking care of PPEs and masks and hand gloves and all these things. Only thing is, even if there is 10% improvement or compliance, and even if there is 10% compliance in all these PPEs and social distancing, I think we are still well off. That's my view. But it's very, very difficult. Neither government can implement or forcefully implement it in each individual, of course. But I can see now spitting on the streets and all bad habits should diminish. That's what I can see. That is also a big cleanliness thing for India, actually.
Sure. So I think Ekta, are you still here? We can't see you.
Yeah. I'm here.
Okay. We can't see you, Ekta. If you can switch on your camera. Sure.
I think my camera is on.
Okay.
Hello?
We can't see you. We can't see you, Ekta.
My video is on. My audio is on. I can see all of you.
Oh, really? Okay. Sanjeev, are you able to see Ekta?
No, I'm not able to see it.
So we are not able to see. It's okay, Ekta. If you can still talk, it's fine. Your closing remarks on how would have things changed after 1 year, like all these safety, security protocols which are implementing, all the cleaning, hygiene. Will all this going to stay back, or will all be get back to our own normal after 1 year?
India is a democratic country, sir. So I think government force this lockdown is happening because government is forcing. Unless and until people recognize that whatever is being done or being told, and they consider as their self-discipline levels, this will only continue till we have penalty ailments, till we have government hoardings and all. But I think now we need to shift from the reaction mode to the response mode. So in this response mode, the feedback and the cooperation from patients or community or local public is very important. And as one of the panelists rightly said that once the case of Marine Drive. So I remember one meme which was circulating that in March, the graph of coronavirus was very small, and the graph of people worried for coronavirus was very large. And it is just opposite in the month of June that the graph of coronavirus is high, but the fear among the people and is very low because they have taken it very lightly. So I think it has both positive and negative effects. But considering this COVID pandemic cooperation and people's unless and until we hello.
Yeah, Ekta.
Hello.
Yes, Ekta. We can listen to you, Ekta. Please speak. Yes, Ekta. Please speak, Ekta. Hello, Ekta. Hello, Ekta. Did we lose her? I think she's rejoined. Yeah. Ekta? Hello, Ekta.
Hello,
Yes,
am I audible now?
Yes.
Okay. So I think unless and until we get cooperation and proper the message of this COVID pandemic, like what message it gives about, I always say it's 5S. It is about sanitization, maintaining social distance and self-discipline, sanitization, and screening. Unless and until we follow this 5S and make people understand to follow this 5S, I think this is only the way forward.
Great. So with this, we will close the panel here, and I thank all our panelists to be having joined here. And before we are closing, I am just requesting one line each from you, that your message to our viewers on this situation when they are all affected psychologically, financially, everyone is affected. One line message to all our audience, which are even in non-health sectors, that how they should deal with it. Sanjeev, I will start with you.
Sorry, could you just repeat your question?
Yeah, Sanjeev, your one line message to all our audience, that how they should deal with the situation around themselves when there is all what do you call, everyone is scared, everyone is worried, people are losing jobs, financial challenges, health challenges, everyone is very much I will say scared at this time. So your message to each of the audience who are watching us, even who are in health or in non-health sectors.
So coming from a scientist and a doctor, this may sound a bit ridiculous, but I feel that one must believe in God and themselves, and the belief and faith in God is very important, but one must make the right effort to make the changes that is necessary. So practice better hygiene and hand control. Be sensible and practical. So being realistic is very, very important, and maintaining the right balance is very important at this given moment in time. And to urge the government also to create the right balance. That is what I would suggest.
Sure. Thank you, Sanjeev. Dilipji, your message to all the audience.
I will also say, hold on, this time will also pass. That's what, because we have seen this is ups and downs, and this is one of the downside we are facing. So more we have resilience and holding capacity, and then we have to preserve our resources, especially cash and whatever, because that is what, and we have to take care of our health the best possible way. And then, of course, government has I will also request government to be proactive in regards to healthcare field. Actually, it's little more empathetic, sympathetic rather about the healthcare providers. That's my message.
Sure. May I request Ekta to give your
Yes, my
message to
one
audience?
liner to all healthcare and non-healthcare viewers is: don't follow and forward unvetted news or forwards. This is spreading so much of miscommunication about Google University and WhatsApp University. So don't follow any unfortunate news.
So with this, I thank all our panelists and all our audience who have joined it here live on the Facebook, and all our audience if you have liked this panel and the overall panels of the day, please like and share this video on your profiles so that the great ideas which have been discussed over the day reach out to all the people. And I thank all the esteemed panelists, Sanjeev, Ekta and Dilipji, for joining this
Thank you.
panel and encouraging us.
Thank you, Dr. Ravi.
Thank you so much.
Thank
you.
you.
Namaskar.
Thank you.
Thank you, my friend. Thank you.
Thank you.
Thank you.